symptoms, and he's also going to address the breast cancer controversy. And from the Middle East, I would like to welcome and thank Dr. Abir Annab. Dr. Abir is a consultant in obstetric gynecology. She is the vice president of the Jordanian Menopause Society. She is a member of the Jordanian Society of Osteoporosis. She is a former representative of Jordan in the Middle East Fertility Society. She is the newsletter editor, and I want to thank her very much for being with us today and talking to us on HRT in subgroups, different subgroups of patients. With us today, I want to thank our moderators, Professor Michel Abu Abdallah. I'm sorry for the misspelling. Professor Michel Abu Abdallah, he is one of the 6 founders of the Middle East Fertility Society, which is based, as I said, in Beirut in Lebanon. He is a former fellow of McGill University in Montreal in Canada, reproductive endocrinology, infertility, and andrology. As I said, he is a co-founder, but he is also a past president and of MEFS, and he is also currently the executive director of MEFS, which is based in Beirut. He is a member of the American Society for Reproductive Medicine International Committee. And I would also like to welcome our second moderator, Professor Amr Nouri, my dear friend and colleague, and the former chair of the Egyptian Representative Committee of the Royal College of Obstetricians and Gynecology. And I am not, again, hiding a secret when I say that he started all these activities and all these training courses, and now the webinars. Professor Amr Nouri is professor in Cairo University and the National Laser Institute, and he is a board member and honorary treasurer of the Egyptian Society of Obstetricians and Gynecologists. And as I just heard, I want to welcome our attendees from the 4 corners of the world. In fact, we have people, the registrations so far have topped 1,000. And as you can see, we have people from Egypt, from Morocco, Algeria, but we also have from Serbia, Montenegro, and Croatia. We have people from Australia, Bulgaria, Sudan, Turkey, Azerbaijan, the Isle of Man, Palestine, Yemen, Qatar, everywhere, even Trinidad and Tobago, and the United States, and of course, the United Kingdom. Thank you very much for being with us. I hope you will find I'm sure you will find the webinar of interest. Then I would like to ask those who would like to post questions to put them on the questions and answer section, not on the chat section, please, to simplify things. And I want to thank our host today, Eva Pharma, who have kindly agreed to host us on their platform today in this Zoom webinar. And then if you want to have a certificate for the CME points, please send your request to this link, which is also mentioned or written in the invitation, which you probably received either through WhatsApp or through the email. And if I would like now to leave the platform for my 2 dear colleagues, Professor Amr Nouri and Professor Michel Abu Abdallah, who might like to say something about the Middle East Fertility Society. Michel.
Well, thank you, Hassan, and thank you for the speakers to accept our invitation. Well, just a few words about the Middle East Fertility Society, which was established in 1992, as a matter of fact. And now the society has a great extension, and it's in the whole region, in the Middle East, North Africa. We do have friends all over the world, and I'm happy to share the screen today with Professor Hassan Salam, who is one of the founders as well. So, and the society is being very keen to spread the knowledge of human reproduction and even menopause, which is unusual in our region. and we have a special interest group for the menopause, and Abir Annab is taking care of that special interest group. So also I welcome Abir and her work at the special interest group for menopause in the Middle East Fertility Society. I will not take long of you, just I want to invite you all to our annual meeting in next December 3, 4, 5 in Amman, Jordan. And we hope to see you all there because we're fed up of the coronavirus lockdown and we're keen to meet our friends again. So thank you very much. And thanks, Hassan, for sharing with the Middle East Fertility Society this great webinar. Thanks for Dr. Murad and Eva Pharma for their generous support for organizing the webinar. Thank you.
Thank you, Michelle. Please, I think Professor Amr Nouri would like now to introduce the speakers. Professor Amr.
Hey, actually, it's a great pleasure really to have this group today, eminent speakers in a very important topics of menopause, which is very important to many of our actually clients. And a lot of people really are confused what to do with the menopause and how to treat it with the different opinions. So it's great to have eminent speakers, international speakers today that can give us up-to-date on the management of menopause. And also it's really great pleasure to have, we have registered more than 1,000 attendees today. So this is really great having from 39 countries joining together. So this is really great from nearly every continent. There are participants, you know. So it's really great pleasure to share the experience together. I will come to our first speaker, Dr. Nick Panay, and I'm sure most of us know about him really, and I was really keen to listen to him. I invited him several times to our conferences, you know, but this time really he's live with us today. Nick Panay, he's the General Secretary of the International Menopause Society and the Director of International Center for Hormone Health. So he's going to talk us about optimizing hormone replacement therapy. Next, please. And I will take a few questions for Nick Panay at the end. So please write your questions and answers. Okay, Nick, please. The floor is yours.
Yeah, thank you very much. Ladies and gentlemen, distinguished panel, it is a true honor to be with you this evening. And it is a difficult time with COVID, and our thoughts go out particularly to Beirut at this extraordinarily difficult time for them. So I would like to take the opportunity of perhaps this silver lining to the cloud of COVID, that we can reach out to the four corners of the globe and talk about the management of menopause. And my title will be Optimizing Hormone Therapy, Past Mistakes and Future Directions. Of course, before we start any lecture, we must always show our declarations of interest, and these are mine. So why is menopause and hormone therapy an important issue? Well, we have an aging population with declining quality of life and health. And I believe that due to fears, myths, and misconceptions about hormone therapy, many women are suffering in silence. Our distinguished audience, no doubt, is fully aware of the problems associated with the menopause. Just to review, these symptoms, which often start before the period stop, the hot flushes, sweats, sleep disorders, mood changes, often associated with menstrual disorders, and then very rapidly following on postmenopausally, potentially urogenital atrophy and dyspareunia in over 50% of women, eventually in the postmenopause. And later on, the risks of osteoporosis, coronary heart disease, and cerebrovascular disease, and potentially increased risks of dementia. Now, many of us used to say to our patients when they came to see us, well, don't worry, the menopause, you'll have symptoms for 2 or 3 years and those symptoms will improve. But we now know from meta-analyses, and these are 6 studies, which estimate the natural progression of vasomotor symptoms during the menopause transition, that these symptoms actually last for much longer than we originally used to advise our patients, on average around 8 years. And we know that 5 to 10% of women continue to have symptoms the whole of their lives. And I'm sure some of my colleagues also have patients, as I do, where they're still having to use hormone therapy in their 70s, 80s, and 90s even, because their symptoms are not improving. Of course, we know the Women's Health Initiative study in the United States, published in 2002, that showed increased risks of breast cancer and cardiovascular disease. And perhaps those risks were exaggerated by the media, had a profound effect on hormone therapy usage, with a reduction from a high of around 30% to even lower than 8% now, or maybe around 5% in the UK, lower in other countries. We know that researchers at Yale, who have done some very interesting research, have shown that 50,000 women, they estimate, died prematurely after they stopped taking hormone therapy as a result of the WHI study. And this is probably related to coronary heart disease and osteoporosis-related fractures. So where are we now post-WHI? Because we know many women, as in this picture here, have suffered needlessly because many practitioners were too concerned to prescribe hormone therapy for them, and many of these women were too concerned to approach the practitioners in the first place. Well, in 2015, a panel, which included myself, chaired by Mary Ann Lumsden, published the menopause guidelines for the NICE group in the United Kingdom. And I'm going to use some of the recommendations from these guidelines to illustrate the benefits and risks of hormone therapy. So with regards to breast cancer, we know that the risk varies from one woman to another. We know that obesity is a particular risk factor. In terms of additional risk, HRT with estrogen alone, we know is associated with little or no increase in the risk of breast cancer. HRT with estrogen and progestogen can be associated with an increased risk of breast cancer. We know from the meta-analysis that we performed at the time with the NICE guideline group, these are the data from the randomized controlled trials, that per 1,000 women aged 50 to 59 over 7.5 years, the baseline incidence with breast cancer was 22.48. In women receiving estrogen alone, and this is largely data from the WHI study, there were 4 fewer cases of breast cancer. In women using estrogen with progestogen, there were 5 extra cases. So that equated to 1 extra case per 1,000 women per year, approximately. The collaborative group on hormonal factors in breast cancer from Oxford published a study in The Lancet, which was a reanalysis of data of over 100,000 women with breast cancer. And these data were prospective and retrospective observational studies. 40% came from the Million Women study, which showed that in women using both estrogen and estrogen progestogen, there was an increased risk of breast cancer, and that the risks were higher than those seen from the randomized controlled trial data. But there were limitations to the study in that because these studies were observational, not all confounding variables could be controlled for. Women, for instance, in the Million Women study were filling in survey questionnaires at the time of attending their breast screening. So potentially could have had a higher risk of breast cancer than the general population. I'm not going to go into great detail about this because I'm sure Professor Brinkat will also be addressing the breast cancer issue in his lecture on controversies. However, what I would like to highlight is that the most recent publication of WHI showed no increased risk of mortality. And looking at conjugated equine estrogens alone, this actually showed after a 20-year follow-up a lower risk of breast cancer with a hazards ratio of 0.78 and lower breast cancer mortality. In women using combined therapy with conjugated estrogens and NPA, there was a small but significantly higher risk of breast cancer, hazards ratio 1.28, but no increased risk in breast cancer mortality. Now, does the type of hormone therapy make a difference in terms of breast cancer risk? These are data from two large studies from France, the E3N cohort, and from Finland, the Finnish cohort study. And it breaks down the risks of breast cancer into the different types of hormone therapy which were being used. And we can see here that in women using estrogen and progesterone, or estrogen and digesterone, after 5 years of analysis, there was no significantly different risk compared to the baseline risk without HRT. However, in the women using other progestogens, particularly the more androgenic progestogens, there was this statistically significant risk. And women using estradiol with digesterone in the Finnish study, again, had no statistically significant difference in terms of the baseline risk without HRT. Now, we know that digesterone is the closest progestogen to natural progesterone, and that potentially natural progesterone and digesterone maintain the balance of apoptosis to breast epithelial cell proliferation in women using hormone therapy with estrogen. However, in women using androgenic progestogens, these have a proliferative effect on breast epithelial cells, and we think this is why the excess risk occurs with more androgenic types of progestogens. So moving on to cardiovascular disease, we know that cardiovascular risk factors occur quite frequently in the women that we see, but as long as hypertension, for instance, is well controlled, it is not a contraindication to hormone therapy. Estrogen alone appears to be associated with no increased risk of coronary heart disease and perhaps a reduced risk. And estrogen with progestogen is associated with little or no increase in the risk of coronary heart disease. These are the data from the WHI study showing that when they were published 5 years after the initial paper, the risks of coronary heart disease were particularly confined to the 70 to 79 age group. But there was a progressively lower risk in the younger cohorts, and particularly the cohort that we see in our clinics, the 50 to 59 cohort. So there may be this window of opportunity to potentially achieve hormone therapy benefits, where in younger women, the blood vessels are still relatively healthy, so the beneficial effects of estrogen on reducing insulin resistance, having a beneficial effect on lipids, lipoproteins, and also improving arterial compliance may come through. But in the older age group, when the blood vessels are diseased, then the prothrombotic effects may predominate, and we have to be cautious in this older age group. These are data from Boardman, published as part of the Cochrane database systematic review. They looked at 19 trials, over 40,000 women, and with HRT looking at all the age cohorts, there was no protection for cardiovascular disease or mortality. But for HRT less than 10 years post-menopause, there was this potential benefit again seen with lower mortality, relative risk of 0.7, and lower coronary heart disease risk of 0.52. So in summary, and these are recommendations from the International Menopause Society, there is evidence that estrogen therapy may be cardioprotective if started around the time of menopause, and this is often referred to as the window of opportunity or timing hypothesis, and it may be harmful if started more than 10 years after the menopause. And this recommendation is supported by all the other society guidelines now. So I believe that the time for the definitive randomized placebo-controlled trial has arrived, where we use the optimum types of hormone therapy with lower doses of hormone therapy in older age groups, transdermal estradiol, where there are particular risk factors, using natural types of progesterone, and looking at women who are in a younger age group than WHI, where the average age was 63, and women as old as 79 were being given relative overdoses of hormone therapy. I think an area which is particularly neglected, I feel very passionately about, is women with premature ovarian insufficiency, so women who go through menopause before the age of 40. We know it is vital that these women have hormone therapy of some sort, be it HRT or the pill, because if they don't have it, not only will it impact on their quality of life, but also it'll have an adverse effect on cardiovascular disease, bone disease, and cognitive functioning later on. And it's my opinion that hormone therapy is probably better metabolically than the pill. It certainly has been shown to have a more beneficial effect on blood pressure, and HRT also appears to have a better impact on bone protection, even though there will be some bone protection from the combined oral contraceptive pill. And I'd just like to bring you up to date with the work that we've been doing in trying to further the education and research and development in premature ovarian insufficiency. So in the UK, we're planning a large study called POISE, which will be a study of pill versus hormone therapy, studying bone density as the primary outcome measure, but following these women longer term, looking at their quality of life, cardiovascular risks, cognitive risks, mood, sexuality, et cetera, and we hope to get good quality long-term randomized controlled trial data from that study, which is supported by the National Institute of Health Research. In October 2020, so the 18th of October, this will be World Menopause Day, and the theme for the International Menopause Society will be premature ovarian insufficiency, and we're in the process of preparing a white paper, a position paper on that with the International Menopause Society. We are also putting together a group to update the guidelines on premature ovarian insufficiency, and we hope to work with ESHRA on these guidelines. And we are also putting together a special issue in Climacteric, and which will be published in June 2021. And we also hope to relaunch our POI registry, where we have already gathered prospective data on over 1,000 women with POI. One of the things that we get very frustrated about is, particularly in the UK, women going along to their primary care physicians, and because of the concerns about HRT, these women are often offered SSRIs, so antidepressants, rather than hormone therapy as first-line treatment for their vasomotor symptoms. And this is something that the NICE group stated very clearly should not be happening. Why might we recommend transdermal hormone therapy? Well, we know that the risk of venous thromboembolism is probably reduced by delivering estrogen through the skin and avoiding first-pass hepatic effects, i.e. prothrombotic effects. But it does seem that the type of progestogen also modulates that risk. Well, we know that the risk of VTE is increased by oral hormone therapy compared with baseline population risk. So if you have somebody who is obese or has other risk factors for VTE, then they should use transdermal. And we know that the risk associated with transdermal hormone therapy, given at standard therapeutic doses, is no greater than the baseline population risk. If we're seeing patients with thrombophilias, we do work with our hematologists, but it's really interesting that the work in France has shown quite clearly that even women with thrombophilias don't seem to have over and above what you would expect particular problem if transdermal hormone therapy is added. And we can see from a number of studies, these are 3 studies, the ESTher case control trial, the UK GP research database trial, and the E3N cohort, that with oral estrogens, you get the expected increase in VTE risk, but with transdermal estradiol, the risk remains neutral. And we also have more recent data, 2 large nested case control studies from the UK, looking at over 80,000 women with primary diagnosis of VTE, matched by age to over 391,000 female controls. And conjugated equine estrogens with MPA conferred the highest risk of VTE, whereas dydrogesterone with estrogen conferred the lowest risk. So the advantages of lowering the estrogen dosage are we reduce VTE risks. We know that lower doses of hormone therapy can still maintain vasomotor symptoms. We know that bleeding also can be minimized with lower doses of hormone therapy because there's less stimulation of the endometrium. These are data from GYC published in the Lancet, showing that the risk of VTE decreases with lowering the dose of oral estrogen. And we're currently conducting a study in collaboration. I'm working in collaboration with the Royal Brompton, with John Stevenson, looking at ultra-low dose estrogen 0.5 milligrams versus 25 microgram transdermal estradiol to see that if you reduce the dose of oral estrogen sufficiently, do you negate any risk of VTE with oral estrogen? It may be that if you give a dose that's low enough, that the risk is neutralized as it is for transdermal. So we're looking forward to finishing that study and hopefully publishing the data next year. We also know that reducing the dose of estrogen, these are data from the Nurses' Health Study, reduces the risk of stroke. And in fact, with the 0.3 milligram dose of conjugated equine estrogens, the relative risk of stroke is not increased with that dosage. So what hormone therapy regimens do I recommend? My tendency is to recommend transdermal estradiol unless that particular individual prefers an oral preparation. So we now have many different patches that can deliver 25 to 100 micrograms of estradiol, or estrogel, 2 to 4 applications per day, or the Sandrina gel sachets, 0.5 to 2 milligrams per day. We mustn't forget that if women only have urogenital symptoms, they can use a vaginal estradiol or estriol preparation, a cream, a vaginal estrogen ring. We know that these are ultra low dose preparations. 1 year of the 10 microgram dose of Vagifem is equivalent to only 1 day of HRT. So we can safely add local estrogen to systemic estrogen if there are persistent local effects, local symptoms, atrophy symptoms. In terms of progestogens, for the reasons I've explained earlier, I prefer more natural types of progesterone, Utrogestan 100 continuously, 200 sequentially. It can be inserted vaginally, as can crinone and cyclogest, and provide adequate endometrial protection. Of course, for the women in the perimenopause, where they have breakthrough bleeding quite often, maybe they have fibroids or endometriosis, then a Mirena intrauterine system, even though it's not bioidentical, still has a very important place, a very important role to play for endometrial protection. And combined oral regimens, I think the Femoston range, which contains dydrogesterone, is a very good type of oral combined preparation. This is something that we mustn't forget, that testosterone is a female hormone and that women produce 3 to 4 times more testosterone than they do estrogen. And we know that the decline in testosterone can contribute to not only a loss of desire, arousal, and orgasm, but it can also affect general well-being, mood, muscle, and bone mass. And after bilateral salpingo-oophorectomy, 50% of a woman's testosterone production decreases within days of the surgery. We're not saying that testosterone is a female Viagra. After all, they are much more complex and require perhaps more sophisticated assessment, diagnosis, and treatment, as opposed to where men have problems with the erectile issues and have Viagra to sort that side of things out. Women, we have to follow a biopsychosocial approach. And in fact, we do need to involve the couple in deciding whether testosterone is appropriate for the couple and for the individual. So with regards to testosterone, even the NICE group recommended that testosterone should be considered if HRT alone was not effective for these types of low desire symptoms. And it's unusual for the NICE group to recommend this when testosterone does not have marketing authorization, even now. So what data do we have? We published a systematic review and meta-analysis in 2017, which showed that as long as you stick to female physiological doses, testosterone transdermally is safe, effective for low sexual desire, and very few side effects. And more recently, a global consensus position statement, which I recommend to you to look at, which was led by Professor Susan Davis from the International Menopause Society, which followed a systematic review and meta-analysis of over 8,000 cases, showed, again, similar outcomes about adequate safety and efficacy, with the only adverse effects being excess hair growth and spots, but no adverse effect on cardiovascular risk or breast cancer. So very briefly, what androgenic options are available. These are, remember, off-label in the majority of cases. Testigel, for instance, is a gel where we use 1/10 of the male dose. Testosterone implants are still available, but they are unlicensed now, but can be used with appropriate supervision. Androfem cream is a cream that is indicated for female use. The only drawback to this, it has to be imported from Western Australia, but we would like to see that distributed more globally and become more easily available and licensed for female usage. And finally, just on bioidentical hormones, because there's a lot of hype about whether it's better to go and get your hormones from a compounding pharmacy. This is not the case, because those compounded hormones are not evidence-based for effectiveness and safety. And as in the recommendations here from the International Menopause Society and also the British Menopause Society, there's a lack of regulation, safety testing, batch standardization, and purity measures. So we should use regulated bioidentical hormone therapies. What about future research? I've said that it's essential, because what we need to do is make the treatment suit the individual woman. So we have preparations now that are potentially breast protective, although this requires confirmation, like Duaviv, where the progestogen has been replaced with bazodoxifene and is used with conjugated equine estrogens. Ospemifene, which is another selective estrogen receptor modulator, which is very helpful for symptoms of vulvovaginal atrophy. And estetrol, which is derived from the fetal liver, is of course recombinantly manufactured, and has been shown in laboratory studies to induce breast epithelial cell suppression in cancer models. So we can see that there are new products on the way that can maximize the benefits and minimize the side effects. So take-home messages are that studies thus far have demonstrated that the benefits of hormone therapy can be achieved with minimum adverse effects. Given current evidence, appropriate dosed body identical or body similar hormone therapy regimens appear to optimize the benefit-risk ratio, but long-term data from large RCTs on cardiovascular and breast endpoints are required, ideally performed during the window of opportunity to confirm the favorable findings thus far. And in the future, I believe that the selective targeting of tissues and individualized regimens will optimize the benefit-risk ratio. Just a little plug for our free educational International Menopause Society Impart program, which is now available. And after completion of all the level 1 modules, a certificate of completion is issued, and also complimentary introductory membership of the IMS for 1 year will be provided. And of course, we'd like you to continue indefinitely being members of the International Menopause Society. I'd like to thank you for your attention. And this is a book that we have just published with Paula Briggs and Gab Kovacs on managing the menopause, which I hope you'll find interesting. And I'm very happy to take questions. Thank you very much.
Dr. Amr, you are muted. You are mute.
Okay. Thank you, Dr. Nick Panay, for this excellent presentation. And I think we'll take the questions for Nick today, because I think Nick will leave early today because he has an important occasion. He has to go. So happy birthday to members of the family. So great. Right. So we have a few questions. The first question is coming from Dr. Ashraf Duwidar and asking about in hormone replacement therapy in post-endometriosis treatment, whether with hysterectomy or without hysterectomy. What do you think about it?
Well, hormone therapy in the context of endometriosis is certainly possible. I think you have to think carefully about the balance of estrogen to progesterone and perhaps increase the dose of the progesterone. People often ask, well, do you still need progesterone after hysterectomy in women with endometriosis? My policy is that if somebody has had a pelvic clearance but had severe endometriosis, where we know they can potentially have distant deposits, and these can lead to a flare-up of the condition again, I think it is important to continue progestogen treatment or to start progestogen or progesterone treatment with the estrogen to prevent that. There are also case reports, very rare, of endometrioid type carcinoma. So again, it will be to prevent that as well. In women with less severe forms of endometriosis, and of course we have to carefully weigh up the pros and the cons, because obviously adding progestogen to estrogen potentially can lead to that small increased risk of breast cancer with long-term use. I find, as I said earlier, Mirena is a very useful option for women with endometriosis. And particularly in the perimenopause, it suppresses the endometriosis extremely well. But surgery may be required initially to clear up the endometriomas before starting treatment.
Okay, we have a question from Dr. Ali Isa asking.
I think he's frozen.
The practical alternative to hormone replacement therapy for alternative of HRT for hormone for hot flushes.
Okay, well, it depends what the context is. You know, why are we looking for an alternative in this patient? Is it because they have fears about hormone therapy, or is it because they have genuine contraindications? I think where women have, for instance, a hormone receptor positive history of hormone receptor positive breast cancer, then we do have to be extremely cautious and think about alternatives. It's important to start with the basics, optimizing lifestyle, diet, exercise. We need to think about whether it would be appropriate to use a complementary therapy, such as black cohosh or phytoestrogens, because phytoestrogens don't behave exactly the same as 17-beta estradiol. There is a selective estrogen receptor modulator type effect. We now have new options as well. There's Femal or Cerelis, which is derived from pollen cytoplasm and acts like an SSRI. And of course, then we have the pharmacological options. We have SSRIs or SNRIs, venlafaxine, 37.5 milligrams, BD typically, particularly helpful also for mood, gabapentin, which can help with sleep if taken at bedtime. And then there are also data for oxybutynin and clonidine. We've been conducting some phase 2 clinical trials using neurokinin receptor antagonists, showing a very significant effect on vasomotor symptoms, reducing the symptoms by 70 to 80%. These are not currently available, but I believe in the next 2 or 3 years, NK antagonists will be a genuine alternative to hormone therapy for those women with a contraindication for treating their vasomotor symptoms.
Professor Panay, I have a colleague from Lebanon. He's asking about the use of tibolone. And what is your view about that?
I think tibolone has a useful place in the hormone therapy armamentarium. It is, we have to remember, weakly estrogenic, so perhaps not for the women with the most severe symptoms, but particularly for women in their mid-50s onwards, where perhaps not such a strong estrogenic effect is required, where perhaps there is low mood or low libido, we know tibolone has an androgenic effect, it can be extremely useful. It also is associated with very low incidence of breakthrough bleeding and a very low incidence of breast tenderness. However, some women do put weight on with tibolone. It's not perhaps metabolically the best type of hormone therapy. And in those individuals, then we need to think about alternatives. And of course, for those women that have androgenic problems, excess hair growth, spots, again, I wouldn't advise tibolone to them.
Another question from Lebanon as well, regarding the use of E3 estriol for vaginal dryness, urethral frequent infections, etc.
I think estriol, as with estradiol, is a very useful treatment for vulvovaginal atrophy symptoms, or as we call them now, genitourinary syndrome of the menopause, and can help both vaginal and bladder symptoms. The principle being the same, that it improves lubrication, it improves collagen and elasticity, it increases the thickness of the vaginal epithelium and the urothelium. And so, yes, equally useful with estradiol. You can choose one or the other. I don't feel particularly strongly which is better. I think you need to try and individualize it according to the response that you get from your patient.
Dr. Panay, there is a question from Dr. Dua Zidan from UK, asking why there is a link between breast cancer and Mirena, but not with oral progesterone.
So Mirena, even though it delivers the levonorgestrel locally, is known to have a systemic effect. It's been estimated, if you like to put it into practical terms, 2 to 3 mini pills per week. And levonorgestrel is an androgenic progestogen. So it is possible that because there is a systemic effect, that we don't see as good a risk profile with Mirena as we do with natural progesterone. Having said that, the data are very limited. We've got 2 large observational cohorts, one which shows a similar risk with standard HRT and Mirena, and one which shows a lower risk. So we have to do more studies. We have to do prospective randomized trials where we're delivering the levonorgestrel locally, and perhaps even using lower doses. We now have the Kylena and the JDES intrauterine systems, which are lower doses, and we know from work with the menopause levonorgestrel system, which wasn't launched onto the market, but delivered 10 rather than 20 micrograms of levonorgestrel per 24 hours, that it was equally effective at protecting the endometrium. So that is the difference. The Mirena is not the best progestogen, but delivered in the best way. Progesterone is not necessarily delivered in the best way if taken orally, but is metabolically and from the breast perspective, very favorable.
There's a question from Dr. Sarkar saying that the availability of HRT is difficult in most of the countries, especially the transdermal. Even oral HRT is not available in most of the countries. So what should be done?
Well, we did go through a very difficult phase where a number of products either were withdrawn from the market for commercial reasons, or they switched manufacturers. But I believe that the situation is improving, and that production should, and availability should continue to improve over the next year or two. Having said all that, I think that the most important thing is that we put menopause and hormone therapy at the forefront of the health agenda, and that we lobby our departments of health and politicians to make sure that companies fulfill their duties and provide adequate treatments for our patients. And we know in some countries it can be very difficult to get any hormone therapy preparations at all. And I think that is a very sad indictment of our society. And this is something that I feel very passionately about. and will campaign until my last breath to try to improve the situation.
There's another question is, for how long should we use the HRT?
So the guidelines from the menopause societies is that we should not put arbitrary limits on duration of usage. The duration of use should be evaluated on an annual basis, carefully weighing up the pros and cons. In some women, it may be that they never need HRT. In others, it may be that they need to be on it for a lifetime. For most women, it will be used for a few years, and then there will be attempts to discontinue therapy. I think if hormone therapy is to be discontinued, the dose should be reduced very slowly to prevent a rebound of symptoms. We also know from some Finnish data that there may be an increase in cardiovascular risks if HRT stopped abruptly. One thing that we do know is that the doses that we require for younger women are certainly lower in the older age group, particularly the over 60s. So I think it's very reasonable to titrate down the dosage and see where we are with symptoms. But we need to take into account the person as a whole. We need to take into account their symptoms, their bones, metabolically, etc., and decide what the best is for that particular individual, and not automatically take them off hormone therapy for the sake of it.
There's a question from Dr. Laila El-Arifi asking what's the dose for Turner syndrome or premature ovarian failure for a young girl, and what type of hormone replacement therapy?
Well, thank you very much for that question. And I could give a very short or very detailed response. If I can refer the doctor to our POI white paper, that will give a detailed account of the doses. But the principle is that for younger women with premature ovarian insufficiency, be it due to Turner's or other causes, they tend to need higher doses of hormone therapy because it's physiological for them to have those higher doses. And then once they get into their 40s and 50s, the doses can be moderated. Of course, in terms of puberty induction, this has to be very carefully worked out according to local protocols. My preference is for transdermal estradiol rather than ethinyl estradiol to be used in small amounts and then increased gradually. And it's all outlined in the paper that we've produced.
There is a question from Dr. Wissam Al-Mashaharawi saying that how can we manage postmenopausal symptoms? If we give estradiol or estrogen only, you increase the endometrial cancer. And if you give HRT plus progesterone, you increase the risk of breast cancer. So what to do and for how many years we can give it?
Well, I think this is, again, going back to what I was saying. We need to think about the types of hormone therapy we're using. And if it's possible to, particularly in women with a higher risk of breast cancer, perhaps use more natural types of progesterone or dydrogesterone rather than more androgenic types of progestogen. But I don't think we can advocate the use of unopposed estrogen. I mean, I have 1 or 2 patients where they have the most severe progesterone intolerance. They get androgenic or progestogenic side effects, PMS type side effects, can make them feel suicidal. And where we've tried everything else and they don't want to have surgery to remove the uterus, then we do give a low dose of estrogen and we monitor the endometrium by ultrasound. But with the more modern types of progesterone available now, and perhaps using it vaginally rather than orally, we can minimize the impact of progesterone and make it more tolerable for them. And we know from the French data, albeit again observational, that the risks for breast cancer do appear to be lower with these types of combinations than the old-fashioned types of progestogen like MPA.
Okay, maybe I will take the last question because I know that you have to leave, and also to give time for the rest of the speakers. But I wonder if you can also answer some of the questions on the question answer Dr. Nick Panay as well, if not answered before. So the last one, what are your recommendations regarding the use of hormone replacement in BRCA1 or BRCA2 positive patients?
Well, I suspect that Mark will be covering this in his lecture. But suffice to say that we see quite a number of patients who have risk-reducing bilateral salpingo-oophorectomy, possibly mastectomy as well. And we give them hormone therapy because we believe, and according to the data, that it doesn't attenuate significantly the benefits of risk-reducing bilateral salpingo-oophorectomy. Of course, if they've had breast cancer before, then that's a different matter, and we have to then think about alternatives. But many of these women having risk-reducing procedures are young, you know, in their mid-30s, 40s, early 40s, etc. So we do need to think about not only their quality of life, but their bones, cardiovascular system, cognitive functioning, in making very careful decisions that are right for those individuals.
Thank you very much,
Dr. Amr. Dr. Amr, can you allow me to, because I think Michel Abu Abdallah has a problem in his connection. There is a question from Nepal, Dr. Aftab Ansari, and she's asking about hormone because it's 2 o'clock in the morning over there, 2 o'clock plus. And she's asking about, or he's asking about the hormone replacement therapy after hysterectomy. Estrogen.
Well, I think
only. I know you've covered it, but maybe we can confirm.
Well, it's estrogen alone, unless history of endometriosis. If they've had bilateral salpingo-oophorectomy, which is usually where we need to replace the hormones, I think the message is think about testosterone as well as estrogen, because we lose 50% of testosterone production from the ovaries. And make sure that we give adequately high doses, because surgical menopause is very abrupt and the symptoms can be very severe.
Thank you very much. Dr. Am.
Dr. Nick, if you have the time, if you can answer a few of the questions, this would be great and highly appreciated. And thank you very much, really, for your presentation and answering the question. Thank you very much.
It's a great pleasure to have been with you tonight, and I hope the rest of the meeting goes very well. Thank you very much.
Thank you very much. Right, our next speaker is Professor Mark Brinkat. As Dr. Hassan introduced him, he's a professor and former Dean of Faculty of Medicine and Surgery, University of Malta, and he's a former honorary clinical professor at Queen Mary University in London. He's going to talk about hormonal versus non-hormonal.
Right. I can't see myself. I have a bit of a problem. Amr, can you hear me?
Yes, we can hear you.
Why can't I see myself?
Because you don't see yourself if you're sharing your slides.
Okay, very good, Hassan. Good. I might need some technical help. The other thing is I'd like to confirm I've got 2 lectures, right, today. So I'll be lecturing later on breast. That's correct. Okay, so I'd just like to all thank you all. First of all, I'd like to introduce myself. I'm still a professor at Queen Mary University of London in medical education, and of course at the University of Malta in obstetrics and gynecology. And I'm an associate dean at QMUL. My conflicts are that I was on council for IMS, EMAS, ASHRI, and I'm still on ISGE. I will be covering some of the work that Nick has done. I've left an intact lecture here so that you can all have it, but the breast cancer slides I will skip over, so I'll have more time to talk about them in the breast cancer lecture. First, I'd like to thank everybody, my friend Hassan, like thank the representative committee in Egypt, which we've had long-standing relationships here. And of course, our heart goes out to our colleagues in Beirut, because we are cousins. We were a Phoenician colony, as you know. We still have a lot of Phoenician heritage here. And Beirut is very close to our hearts, and that's an appalling accident that they've had. And hopefully, once again, they will rise like your legendary phoenix from the ashes. But we wish them well. So today, my brief is to talk to compare hormonal and non-hormonal treatment for menopausal symptoms. So we will cover some of the questions that have been asked, I hope. So there has been an interest in options for non-hormonal and non-estrogen forms of treatment following, of course, WHI, as you've heard Dr. Penay just talk about.
We cannot see your slides. We cannot see your slides. You have to share your screen.
It is shared. Okay, let's go back.
Share your slides. Share screen.
I have a problem. Go back to Zoom here. Yes, it was okay.
Share screen at the bottom of your
Yeah, but
screen.
I don't have it. Here's the problem.
Yeah.
Let me just escape again.
Is it open already or not?
It should be open.
Yeah. Go to share screen at the bottom. At the
Right now, I want to go back to where I was before, actually. Oh, this is bad.
No, no problem. Don't worry.
I cannot get the original Zoom.
Mark, you can go out and come back again on the Zoom.
It's probably easier
and come back.
if I do that.
Log out and maybe we ask Dr. Nick Panay to answer one or two more questions while you are logging back again.
Yes, I think so.
Okay.
So I've returned to meeting here.
Do you believe, Dr. Panay, do you believe in phytosoya?
I believe that it has a place. Again, I think we should give our patients a choice. And
are we okay now?
Women will often obtain these preparations over the counter before even seeing us. There are some preparations which are better, more evidence-based than others.
I'm sorry, Hassan, can you see me now?
Yes, you're okay now.
Okay, very good. Sorry, Nick. I'm sorry, Nick.
Yeah. Okay. So just to finish on that one, so promensal, red clover isoflavones, femoral, those particular ones have had a number of trials performed, both laboratory data and also clinical trials, which show benefits not only in terms of symptom relief, but also some benefits for metabolism, bone, and cognitive symptoms as well. So I think they have a place, but the important thing is that in those women that continue to suffer with symptoms, that they don't continue to try with phytoestrogens when in fact, they could benefit from hormone therapy and therefore, need to switch at the correct time in order to maintain their quality of life and well-being.
Okay, thank you very much. Okay, Prof. Brinkat, okay, the floor is yours. Thank you.
Right, so my slides are fine now. So right, so I'll just try and see myself only. Okay, so as Nick has been saying now, there's been, the reason why there's been interest in options for non-hormonal preparations is because of mostly WHI and the post-WHI world. However, we are still left with the reality that estrogen therapy provides a comprehensive multisystemic treatment. And the benefits have been well known. I mean, studies on HRT, on estrogens now have been ongoing for over 70 years. And replacing estrogens with alternatives is still a challenge. We do know that the menopause transition is divided into short-term and long-term symptoms, and the therapy is either targeted or multisystemic. So this is a general lecture, basically. In general, non-hormonal treatment tends to be targeted to various organs, to hot flush, to bone, for example, to individual symptoms of the menopause. But also, you can have an on-estrogen treatment, which is also hormonal. And this can also be both targeted or multisystemic, such as, for example, tibolone or, for example, SERMs. Okay, so if we go to the short-term symptoms, these are very, very well known. Hot flushes is the most characteristic symptom of the menopause, with 75% of women still having hot flushes at the beginning of the menopause. But 25% of women would still be having hot flushes up to 5 or more years later. Irritability, lack of concentration. Then we have our psychological symptoms, such as anxiety, depression, irritability, and lack of concentration. Psychosexual ones we have heard about, demotivation and loss of libido. Atrophic symptoms, such as vaginal dryness, vaginal atrophy. Urogenital syndrome presents very often with nocturia of more than waking up once to pass urine at night, so more than once is regarded as symptomatic. Dysuria, polyuria, and incontinence. Many of these symptoms are symptoms of cystitis. And this cluster is wrongly attributed to cystitis. So these women are being given antibiotics time and time again for no good reason, causing damage to their own flora and causing damage to their base of bladder very often and to the epithelium. the transitional epithelium. And then, of course, we've got prolapse, which is the final giving up of your pelvic floor muscles as your collagen content decreases, declines, and is probably the result of former damage that you might have had in the past. Very importantly, in our current COVID climate, is the immune response. We know that the estrogens play a very major, prominent part in our immune system, both in your BNT lymphocytes. Indeed, we had a paper published in the Lancet many, many years ago, and it immediately presents as aches and pains in your joints in the morning, for example, and the increase of other immune conditions, such as asthma, might present for the first time at the menopause, or psoriasis. And I'd just like to remind you, this COVID world, that women are having less COVID presentation, the disease presenting, the coronavirus disease presenting, than men. People in ITU tend to be 2/3 men and 1/3 women. And this is still an ongoing source of interest. There's been a study in Hungary looking at the role of conjugated estrogens in people with COVID, with bad symptoms of COVID. And that study is still ongoing, but primarily non-peer-reviewed publication seems to be interesting. So is it the presence of estrogens that is doing this, or is it the presence of excess testosterone in men? Certainly estrogens seem to be protecting even against viral illness. Then we have our long-term symptoms, which are well known: bone loss, connective tissue, cardiovascular disease, cardiovascular accident and stroke, and Alzheimer's. And I've divided these into these components purposely, as opposed to go just bone loss, cardiovascular, Alzheimer's. These three are the common ones, but bone loss implies connective tissue loss as well, both in your skin and your cartilage. And a stroke is certainly a bit different to a heart attack. So, starting with non-estrogen alternatives for hot flushes, where we've heard that we do not like people using these drugs as first time, but nevertheless, this is happening. Clonidine was a very early candidate. There's a clonidine that's been established as 0.1 milligrams AM and PM. Gabapentin is known as an anti-epileptic, and the dose there is 300 milligrams 3 times a day to get the same, more or less the same result as you'd get with the lowest dose of conjugated equine estrogens. SSRIs like fluoxetine, otherwise known as Prozac, the dose here is about 20 milligrams. Paroxetine is given from 110 to 20 milligrams. Venlafaxine, an SNRI, a serotonin receptor inhibitor here. That is centrally acting drug, and the dose there is about 27.5. And all these will give about a 60% relief of your hot flushes, as opposed to estrogens, which give a 90% relief of your hot flushes. Anyway, for people who cannot take estrogens, these are alternatives. A selective serotonin receptor inhibitor, that's what they are. Others are these conglomerate of molecules. One is black cohosh, which we've heard a lot about. Really, if you look at it, if you look at the literature on black cohosh, it actually behaves as a SERM. And we know that there are a lot of SERM-like molecules in nature, actually selective estrogen receptor modulators, and they are actually primitive, nothing other than primitive estrogens. Estrogens have come a long way in evolution, and certainly we have estrogen-like molecules in nature that are very, very widespread. You have to excuse me because the Egyptian sacred cat has just come on my desk. Let me just poke him down. Excuse me. There he goes. Invaded by your sacred cat. Winston. That's Winston. Sorry. Okay. Vitamin E. 800 international units a day. The randomized study showed to be of some use. Oil of evening primrose and this IEP oil here. All these actually have got SERMs-like action because, as I've said before, estrogens are not just a sexual hormone, but come down from some very primitive plants. They come down a long way from evolution. They're highly conserved molecules. We have found estrogen-like molecules in brown algae here in Malta, right? There's a French firm working on them extensively. And it's very interesting because it just bypasses your estrogen receptors or also occupies some estrogen receptors. And finally, this is a bit excessive, stellate ganglion blockade has been shown to be effective in stopping hot flushes. All this effort instead of using estrogens. borderline molecule like 4-phytoestrogens, a lot of interest in Australia on them, soy and red clover. Royal Women's Hospital in Victoria has published a whole pamphlet on this, and isoflavonoids in various forms are quite potent, and you might get, once again, a 60% response in hot flushes using these estrogen-like molecules. Once again, this highly conserved molecule, they call estrogen, has been widespread and very important throughout evolution, and it seems to be fundamental in cell-to-cell communication, very early life forms. What about psychological? Well, our paper in The Lancet some years ago carried out between the King's group and the very skeptical Maudsley group from the Maudsley, who are psychiatrists. They came and attended our menopause clinic, and they found that had they been left to themselves, psychiatrists would have treated 75% of women attending our menopause clinic on their first visit. After 3 months of HRT, this group dropped to 25%. So there's a significant difference. The alternative treatments that they would have started our patients on at the time would have been anxiolytics, SSRIs, your selective serotonin receptor inhibitors, and your SNRIs, your noradrenaline receptor inhibitors. But there is a problem in using these psychiatric drugs. The problem is that you get increased lethargy, you get demotivation, and you get a lack of compliance, and they are really addictive, and lack of concentration. So it's a high price to pay when estrogens do exactly the opposite. This has been shown time and time again. When it comes to loss of libido, the big question, Nick has just shown a very elegant number of slides on testosterone. Our interest in androgens is long-standing. Women have testosterone. We men have the same amount of estrogen that a woman has in her follicular phase, being produced in places like the brain and fat and other sites. The only difference between, well, the several differences between men and women, I suppose, but from an endocrine point of view, from a testosterone point of view, is just that we have 6 to 12 times. So we are really just performing as men simply because we have 6 to 12 times more testosterone than women otherwise has. So it's quite clear that in men, estrogens are important, particularly in prevention of osteoporosis and our brain function, where several of the estrogen metabolites are in fact neurotransmitters. But in women, androgens are also important, not just in loss of libido, but things like concentration, initiative, drive. These are symptoms that have been shown to respond to testosterone. Now, timolol, interestingly, at 2.5 milligrams a day, which is really a glorified gestogen of some sort. It's a progesterone-like compound related to dihydrogesterone, which is the faston, with some estrogenic effects. But timolol has been shown to improve this problem of loss of libido. And hence, there's been a revived interest in timolol because it's a readily available drug that has been shown to improve libido, apart from being a very useful form of HRT. T-sex, we've got SERMs. Hang on a sec, he just wants to have a look. Okay, there you are. Can you see? Okay, ready? Thank you. I'm just being invaded. Right. T-sex. Timolol only lately called itself a T-sex because really the T-sex SERM came from the combination of the SERMs, bezodoxifene, and low-dose CEE. Now, unfortunately, this has been a victim of WHI because research in this very exciting molecule combination really stopped after WHI. And yet the results with bezodoxifene and CEE were very promising, particularly from a breast cancer protection point of view. And from a symptom point of view, the response was excellent, really. And black cohosh, we've already described, is the SERMs-like molecule, so it's no surprise that you do get psychosexual responses. Okay, so what about this distressing vulvovaginal atrophy? Particularly the vulvovaginal atrophy that you get, which is the worst possible vulvovaginal atrophy, is the one that you get post-hysterectomy in breast cancer women who are on aromatase inhibitors. These pose a huge problem, they're such a problem that in this exceptional group of cases, purely off license, we have had to resort to low-dose vaginal estrogens. And this even on the advice on oncology, because the pain, the recurrent infections, the smelly discharge was just too much in this group of women. And they, of course, have had relief with estrogens, but it's always knowing that the oncologists first were criticizing us for using estrogens, and then in the breast cancer women on aromatase inhibitors, they found that they did have to give these women, these poor women, some relief because symptoms were terrible. Well, there is a bit of an alternative now that's upcoming, as you all know, the vaginal lasers. I myself have a vaginal erbium laser, not a carbon dioxide laser, and the studies are coming out. I can anecdotally say that we have seen some very positive results as regards vaginal dryness, vaginal atrophy, mild prolapse, mild incontinence, and dyspareunia. And certainly the results with dryness and atrophy are quite, are very interesting. Erbium, the vaginal laser, well, erbium laser is also useful in treating the vulva. We've had women with lichen sclerosis or with vaginal dryness who've been responding very well, when otherwise they would have had very poor response to low-dose estrogens, or they might have had a contraindication to the use of estrogen. So the relief rate is, there's Marco Gambacciani, who's produced quite a lot of data on this, and Ivan Fistonich, an 80% relief rate in these women for 18 months. And this is backed up by histological studies that show that there is relief. And it can be used in combination with other treatments. So if you are eligible to be a candidate for estrogen replacement, you can use laser with low-dose estrogens. It's just like Nick said, you can get away with lower-dose estrogens if used in combination. Other non-hormonal preparations, well, there are moisturizers. There's a lot of vaginal moisturizers around, and they will give temporary relief, but they're not going to give histological relief. You're not going to see any difference in your epithelium. But let's just think of what happens to your epithelium in your vulvovaginal atrophy. Well, it's an exaggerated manifestation of what happens to your skin, really. Your epithelium, skin simply becomes thinner with more keratin in it, so it's itchy. You lose your retipegs, and your collagen becomes much thinner, and there's less collagen around, and it's more, and the dermal papillae are also lost, so you get more chafing, and you get easily more bruising, thinner skin, cracks, cracked and infected, you itch, get more keratin, it's a vicious circle. So you can use local estrogen therapy, which is targeted, like the E3 that we spoke about earlier. There is now ospemifene on the market, which is a SERMs. It's an oral SERMs, which gives vaginal relief. So it's very interesting. And there are vaginal moisturizers, probiotics, and of course the phytoestrogens such as soy gels, which can be used, which are really low-dose estrogens. That's what they really are, and that's the same effect. And they do carry the same warning as estrogens from a breast cancer point of view, although of course it's just a warning and not a reality. So we come to osteoporosis, and you will see that we start with treatments, alternatives to estrogens, where calcium has been around, been in and out of fashion. There's still a high fracture risk. Might be useful in these women who have a high fracture risk. There's no real evidence in terms of safety efficacy. There are complications because excessive calcium, especially in climates like ours, which are dry, where women can get easily dehydrated, they do carry an increased risk of renal stones. And later there's been a cardiovascular risk described to excess calcium intake. But we have to be careful here, because nowadays some countries like ours depend on water from reverse osmosis plants. So no longer does our water have a high calcium content. It now has, in fact, a very reduced calcium content. So you have to be very careful as to where your source of water is coming from. Water is the principal source for your calcium intake, really. And of course, you get from vegetables and other things, but it makes a big difference as to where your water comes from. So vitamin D, once again, a lot of mythology with vitamin D. Originally, the dose advocated was for 100 to 800 international units. This has been shown ever since we've got very good sensitive tests, serum tests for vitamin D, and since ranges have been established, this has been to be very deficient. And vitamin D deficiency in our societies now is rampant. People say this is not possible. We've got a high, there's a lot of sun around, and this vitamin, which is actually another primitive hormone, 90% of which is derived from cholesterol conversion in your skin, and cholesterol conversion is the basis for all sex steroids. You remember, once again, you can only get 10% from your diet, and in a system where most of your molecule comes from your systemic conversion from yourself, then this becomes not a vitamin at all, which by definition is something that you've got to get externally. It becomes a hormone like any other. But the thing is, our lifestyle is very different. We were designed to work out in the sun, either as farmers or on the sea. Nowadays, with our indoor type of lifestyle and using sunblock, which is a good thing for our skin, we're not living the same lives that our ancestors lived. I mean, I've got solar damage, as you can see on my face, since coming back to Malta. I'm no longer that young photograph that Hassan digged out from somewhere. But anyway, but we find ourselves to be vitamin D deficient. So the current dose that is recommended for people who are at risk of osteoporosis is 4,000 units. And studies on 4,000 to 8,000 units a day have not been carried out. I have to say that these are not toxic levels. Toxic levels are at around 100,000 a day. Okay, so these are not toxic levels. So anybody who's worried about using 4,000 to 8,000 international units of vitamin D3 a day should not be worried. Just monitor them like we monitor thyroxine, like we monitor estradiol. There are serum assays. Stick to that, and you know where you are. So what has happened then? Vitamin D supplementation has been shown to independently lower the risk of fractures. But what has happened is that concurrently with this realization that we need an increase in vitamin D, we have failed to realize that our serum calcium levels have also dropped due to our diet. And nowadays, there is a need, and studies are ongoing, to not just look at these higher doses of vitamin D as a relationship to osteoporotic fractures, but to look at a combination of high dose vitamin D and calcium supplementation. So all these studies have got to be redone because they have been essentially underdosed in the past. Biphosphonates, we are familiar with alendronate and zoledronate. Excellent, but not to be used. Why have they been being used in women in their 50s? Women undergoing their menopause, the type of women we see are normally women between the age of 50 and 55. We don't see women at 65 and start on an HRT. This was one of the big defects of WHI, is that a lot of it is attributed to women who started on HRT late because of the conditions of that study. In response to the decline in use of HRT, we had physicians starting women, young women, on biphosphonates. And this has caused long-standing problems because biphosphonates, as you know, stay in your system forever. They poison your osteoclasts forever. And then you start getting these odd fractures happening, atypical femoral shaft fractures, or problems in your jaw and dentists. So anyway, but on the other hand, when used properly, they are very good. They will reduce both vertebral and hip fractures. I will quickly go through serums now. Raloxifene, tried and tested, 60 milligrams a day. We reduce vertebral fractures. We can use it in young women. We will talk in our breast cancer lecture more about raloxifene because it actually prevents breast cancer in estrogen receptor positive women. And bezodoxifene, once again, does that. Will prevent hip fractures in selected cases. Now, in combination with an estrogen, of course, both are useful. Teriparatide, very expensive, used in very severe osteoporotics. I will just mention it here for completeness sake, but there it is. Its only role is to be used in conjugation with something else. Denosumab, once again, very fashionable, anti-rankle. It's a genetically recombinant antibody treatment. It's used for 60 milligrams every 6 months. Very exciting. Vertebral hip fractures reduced. Problem, there's a rebound if it is stopped. So initially we were told it can be used for just 2 years, but now we realize that you've got to carry on with it. Strontium ranelate, very interesting. It did increase bone mass. It did increase your vertebral and non-fractured vertebral fractures. Now it's been withdrawn because of cardiovascular safety risks. Get to cardiovascular disease. We do very well with statins, fibrinates, antihypertensive. So I think a menopause doctor should also be a physician. He should be very well aware of how to use statins, how to use fibrates. The difference between fibrates and statins, women do better on fibrates sometimes. Antihypertensive have got to be aware that what our colleagues are using, and they're using ACE2 inhibitors in this environment. It's probably worthwhile, being careful about them. But on the other hand, even in this COVID era, we are being told that women should still stay under antihypertensives if they are ACE2 inhibitors, even if coronavirus does gain entry through ACE2 inhibitors. So they are not contraindicated in women who have got SARS-2. Insulin sensitizers like glucophage has made, like metformin, has made a huge comeback. and we'll talk about this later as well. But really, HRT is useful in the recent menopausal women below 60 years. There is a window of opportunity for cardiovascular disease. If you start HRT between 50 and 55, that's where you will see your bigger impact on incidence of cardiovascular disease, maybe up to 60 years. Nick did talk about this window of opportunity. Once again, Alzheimer's, are there alternatives to estrogens? We were just beginning to have major studies on Alzheimer's. Certainly the death rate from Alzheimer's is less with HRT, and this is from WHI itself. You can use other conditions, other drugs like acetylcholine, glutamine, and all the others seen there. So there are alternatives to HRT. Of course, in this case, these are first-line drugs. They're not, you know, HRT is very much a second line in the treatment of Alzheimer's, maybe even a third line. Whereas in osteoporosis, there's an argument as to whether it should be first line or second line, depending on the age of the individual. Okay, depression, agitation, aggression, hallucination, delusions, all these have to be treated individually. Once again, here is your group of drugs that I use: antidepressants, anxiolytics, antiepileptics, neuroepileptics. But Alzheimer's is very much like an osteoporotic fracture. It is an end result of the brain shrinking, basically getting less and less and less until some insult tips it over the edge and you get dementia. With osteoporosis, you get less and less and less bone. Some insult then gives you a fracture. So Alzheimer's needs to be seen with that paradigm in mind. Alternative, we'll get to the end now: acupuncture, reflexology, aromatherapy. These are all alternatives that have been used to HRT. I suggest they should be used with HRT. There is room for acupuncture, reflexology, aromatherapy. Lifestyle changes, we're always saying we should diet more, change our environment, you know, avoid coffee addiction and so on. Yes, great. I'm sure everybody's doing this. Exercises. I think you need to start from a young age, really. We need to inculcate the importance of exercise in girls from a young age. There is, in some countries, ours included, unfortunately, there's a big difference between the amount of exercise boys are exposed to when they go to school and the amount of exercise girls are exposed to when they go to school. I'm happy to say this has now changed, but in the past, you find that boys' schools were into sport, girls' schools were less so. Now, of course, they're all co-ed, so they're all exercising the same, but this has led to problems in the age groups we are currently seeing. Okay, the biggest challenge was WHI. We'll talk about this in my breast cancer lecture, right? And just gives you an idea of all these women who are recruited in WHI between 1993 and 1998, women with an intact uterus, women without a uterus, and the number of cases we're talking about in 2002, which collapsed the world of HRT after a good 6 years, were 8 extra cases in 10,000 women, 7 extra cases of heart attacks in 10,000 women, and 8 extra cases of stroke in 10,000 women in women who were on estrogen and MPA. Not so in women who are on estrogens only. But there was also always straight away an observation there was a reduction in bowel cancer and osteoporotic fractures. And even at this early stage, we had significant changes. I will now skip quickly because I will be discussing this later. You will see, if you look at this window of opportunity between 50 and 59, all-cause mortality was actually less, significantly less in every single cohort. So this is the window of opportunity we keep on talking about. We could not understand what they were on about, simply because we were talking about the women we see aged between 50 and 59. We don't see women at 70 and start them on HRT. You know, we see women between the age of 50 and 59. And in those groups, you will see that the risk, the RR, the risk ratio is always to the left of the mean. In some cases, you get significant differences as well. And this includes breast cancer with CEE alone. And this is from JAMA 2000, the paper from 2017. There is now an update on breast cancer from 2020. So this JAMA paper is very important. Now, you're in Alexandria, so I'll leave you with this bit of logic. I'll come to it later on. And you have to remember that association is not causation and correlation is not causation. And what's happened in the world is that everybody saw an association of an RR of 1.28, and really, unless you have an RR of 3 to 4, and there's a paper by Stevenson here, by Farmer and Stevenson, in the current climacteric, This figure of 3 to 4 comes from a director from the FDA, and really, you know, you just wonder if we've made too much about a big thing, because of course something is associated doesn't mean it is caused by it. You have to find a biologically plausible reason to come to a conclusion. From a progesterone point of view, unless you have endometriosis, where there's some debate, you do not have, if you don't have a uterus, just do not use a progestogen, easy. John started always to say, no uterus, no progestogen. You don't need progesterone, because the only reason why you use progesterone or progestogen, and you have to distinguish between progestogen and progesterone, is to prevent endometrial hyperplasia. So no uterus, no progestogen, no problem. There was another one to say no problem. Modes of delivery of estrogen, we have oral, transdermal, gel, vaginal, implant, depot. We are spoiled for choice, but it is multisystemic. How does this compare with all the other drugs we've been talking about? Here we have a one-stop shop, a product that is multisystemic. That's a natural product. It is a bioidentical product. Actually, 17-beta estradiol is bioidentical, and you can choose whichever route is appropriate for your the individualization of your patient. Each patient has got to be individualized. One of the problems we had in the past was there was one formulation given to everybody in the same way, and this caused problems, even if people did not need it. So your patients, your clients, they need to be selected properly, and you've got to tailor the treatment depending on their needs. Hormone implants are still very useful. Challenges now, the last 2 slides. We've got to think of alternative treatments like SERMs, tamoxifen, raloxifene, bezoxifene, T-sex. Tamoxifen we'll talk about in my breast cancer lecture. These are real alternatives. T-sex is tibolone, basically, or a combination of bezoxifene and conjugated equine estrogens. Here they are, tibolone, bezoxifene, and Premarin. You can make up your own with raloxifene and a 17-beta estradiol if you like. Premarin, we normally use the 0.625. With bezoxifene is the 0.3. Actually, it's an even lower dose. So you can get away with a lower dose of estrogen if you have a SERMs. But you need a bit of estrogen to get rid of your hot flushes. Treatment of osteoporosis, we need hip and vertebral fractures are both reduced with these alternatives up here. So they've been proven. But this combination are also useful in relieving libido, vaginal dryness, flushes, and sweats. These are non-hormonal, sort of hormonal, non-hormonal preparations. And these are the others we spoke about, a whole load of alternatives for treating postmenopausal women, for treating general symptoms of postmenopausal women. We spoke about these individually. And so in conclusion, when considering an alternative, I'll just look at this. Okay, we're considering non-HRT alternatives to treatment of the menopause. The aim is to treat different systems individually rather than a multisystemic approach offered by hormone treatment. So if you look at non-hormonal alternatives, they're treating individual problems, not the whole. The treatment options are divided strictly into non-hormonal or non-estrogen option. So the non-hormonal ones are biphosphonates and so on, that we spoke about, or SSRIs, for example. And there are non-estrogen options, but these can also be hormonal. So there are 2 classes, one which is non-hormonal completely, and one which, although it's non-hormonal, is also of hormonal origin, i.e. they're all cholesterol-based originally. So there are useful alternatives. They can exist, but apart from osteoporosis, in osteoporosis where there's now a big body of evidence of useful treatments, very few are as effective as estrogen treatment. And I think this is the end of my lecture. I've got some references here, which you are welcome to see. And I think this paper is now open to discussion. Are you okay? I think Michelle is muted.
Michelle, please unmute your mic.
Thank you, Professor Brinkat. Beautiful presentation. I have always viewed in menopause in all my lectures. So I admire your dedication and devotion for the menopause and the health issue for postmenopausal women. As a matter of fact, we do have question and answers And Marwa Abdullah is asking, could we use dydrogesterone alone to treat hot flashes?
Yeah, the simple answer is yes. Yes, you can. Dydrogesterone is a very good progesterone-like compound. It's a progestogen, but from a structural point of view, it's actually a stereoisomer of progesterone. So yes, you can. You can. The downside is you might get some mild progesterone-like symptoms. Don't forget, progesterone can give you PMT-like symptoms, a bit of bloatedness, a bit of breast tenderness. But out of all the progestogens that we have available, forgetting about the natural estrogen, natural progesterone, which we have in form of progestin, where you need a high dose to get an effect, dydrogesterone is a very useful and important progesterone-like compound. And even, I mean, from the metabolic point of view, it's the one that's closest to progesterone anyway. And yet you can take it orally, and it's biologically active. So yes, you can. But Livial, I have to say, Livial is very close. Similarly, it's a very similar compound.
Well,
Keep alone.
This is my question. What about in breast tenderness associated or secondary to HRT? What about the use of letrozole as an add-on therapy, like giving on Monday, Wednesday, and Friday?
Right, right. It all depends on their half-life, okay? So the half-life of letrozole is only, I think, 18 hours. So there's no point in giving it. It's a very bad idea, actually, to give shocks to your receptors in that way. That's number one. Secondly, the breast tenderness from HRT normally is dose-dependent, and normally should not last for longer than 2 months. So you should wait for 2 months first. Instead of using Femoston 2 milligrams, use Femoston 1 milligram, for example. And really, you've got to remember, these women have been estrogen deprived. Normally, the ones who have breast tenderness are the ones who have been estrogen deprived for a while and have breast tenderness as their breasts get rehydrated, if you like, because it's a water content effect that does it. So the breasts become tender again, just like they do in a young girl, for example. And that sort of breast tenderness is nothing to worry about and normally resolves after a while. If, on the other hand, you are resurrecting some fibroadenosis, then that's a different matter altogether. Then you have a problem. It's normally caused by the gestogen rather than by the estrogen. But in that case, just use the lowest dose possible. We have Femoston Conti, for example, which is quite low, and you might get away with it. Letrozole, there's been some work on letrozole and androgens in combination. And they've been very interesting because they have actually shown a reduction in breast cancer rates, whereas at the same time preserving your bone density. Don't forget that letrozole, being an aromatase inhibitor, really does get your bone density down very, very quickly. One other alternative you might consider is a SERMs. You might want to use a Vista instead. You can try raloxifene, and raloxifene does reduce breast tenderness. Was, I mean, the only downside with raloxifene, which is an excellent drug, which we'll talk about later, is that you might get hot flushes. So in which case, you might want to use raloxifene and maybe a low dose of estradiol gel, which will suppress your hot flushes very nicely and give you the benefit of SERMs.
Very nice. Emmanuel Gindi from Egypt is asking the prophylactic dose of vitamin D in post-menopause.
Yes, I tend to get a serum level. Over here, we've got very good assays for vitamin D. Now we have got the American Society of Endocrinologists, which have established the range. The new range is between 30 and 100. Very few people are within the range. You'll find that you might find maybe I'm sure your farmers, your fellaheen, they will have good vitamin D levels probably. But in the city, you will find maybe most people are borderline. And after the menopause, they become even, the vitamin D level becomes even lower. So I would personally always start at a dose of between 2,000 and 4,000 international units of vitamin D3. And then after 3 months, measure the vitamin D levels. Of course, diet is important, but diet will only contribute 10%. So if they increase their fish intake and their green vegetable intake, for example, and exercise, they can push up the vitamin D levels, but not sufficiently if you are your average Cairo inhabitant living in a decent house, you know, with your average lifestyle, you will find that you're vitamin D deficient. Because we have a special enzyme which is involved in making us not have toxic levels of vitamin D. You'll find that in the Middle East and in many southern populations, we have a self-regulatory mechanism so as not to have toxic levels of vitamin D. If you're working out in the sun from dawn to dusk with no factor 80 creams, you know, you will have toxic levels of vitamin D. But once we started covering up, staying inside, stuck to our computers, watching our monitors, we found this I won't say pandemic because it doesn't sound right, but this really common vitamin D deficiency, which incidentally was first identified in Saudi Arabian women.
Well, I have noticed that most of our women in the Mediterranean and even in the Middle East, they present with vitamin D deficiency. That would be the case in Malta as well?
Exactly, yes. We found, when I started with my vitamin D studies, I was criticized. But if you just look at photographs of Maltese from the last century, for example, they weren't starving, right? They were quite healthy, but their skin looked like leather boots. They were aging prematurely. Their skin, obviously, they had a lot of solar damage. Our Bedouin, Abdiwa farmers would have, we have congenital balding here, so that have a white patch on their head where they wear their cap, but the rest, you know, they might be blonde, but the rest would be, they have a lot of solar damage, like Australians, are the same. And of course, that was the lifestyle here. But suddenly, after the Second World War, lifestyle changed dramatically. The economic conditions improved dramatically. And that's where we are now. And other diseases have been related to vitamin D deficiency. COVID itself is much worse in vitamin D deficient people than in vitamin D replete people. But we've got polycystic ovaries. We have even low sperm counts have been related to low vitamin D deficiency. Endometriosis has been related to vitamin D deficiency because all the vitamin D is an important component of your immune system. So this is it. So we give vitamin D routinely to all our infertile patients, for example.
Great. I have a question from Wissam Al-Mash'arawi. He's asking the support that you support the use of vaginal estrogen in case of mastectomy for breast cancer.
Yeah.
So how long can he give vaginal estrogen? And what is the proper frequency also?
This is very important, Michelle. This is important because, right, I had one particular patient I remember who was on HRT, on HRT for a while, Progano for a while, and she had and she did turn up with a breast cancer. She never attended doctors, never came for checkup. She self-medicated, but even so, she was one of the unlucky ones with an estrogen receptor positive breast cancer. She went straight off to the Marsden from here, had a bilateral mastectomy, had radiotherapy, had chemotherapy, right? She had the works when she was advised to have a small lumpectomy. And she'd had a hysterectomy in the past. So here was this woman with radiotherapy, now being on maintenance doses of Arimidex, and she had the worst vaginal atrophy imaginable. So, and this was at the height of WHI. So she was very kind. She said, listen, I'm just unlucky, sir. But her doctor, of course, her oncologists were saying that this was obviously estrogen related, you know. The fact being on 2 milligrams of Progainova did it. The fact that her breast tissue itself produces far higher levels than that was irrelevant. But anyway, the long and the short of it was that she was getting this severe atrophy, greenish discharge, infections, trichomonas, the whole lot, all the time. So her doctor, her Maudsley doctor told me to start giving her vaginal estrogens. I said, okay, I have no problem with that, but I want it in writing. Okay, so anyway, so after that, they have been sneakily using Vegifem, 10 milligrams twice a week on these patients. I don't say sneakily, I would say correctly, because the change was dramatic. Her tissue improved straight away. Her vaginal length became normal. She had less pain. She was able to tolerate intercourse. She once again started medicating, and off she went, and there was no problem. But you remember that Vegifem decreased their dose of 17 beta estradiol from 25 milligrams to 10 milligrams to a tiny dose. So they can even use it every day, really. The serum levels are very, very low, but the prescribed dose is 2 to 3 times a week, and I would always consult their oncologist and get their permission. This is not scientific, this is medical legal. Scientific, they can use it every day, but medical legal, consult.
I have an interesting question from Hayat Sharaf.
Okay.
What is the best treatment regimen for patients with signs of Alzheimer's and have multi-system morbidity, diabetes mellitus, hypertension, and CVA?
And what does your question want? What was the question? I'm sorry.
She's asking about the best treatment regimen for these kind of patients.
Well, I mean, by the time you've got to Alzheimer's, you've had your multiple osteoporotic fractures. So it's a bit late, really. As you know from if you look at the 2018 JAMA paper, you reduced mortality in Alzheimer's in those patients treated with HRT between age of 50 and 59, and they were followed up for 18 years. So certainly a significant reduction in mortality from Alzheimer's. It's one of the few significant changes. So certainly there is your answer. WHI, the best randomized control trial ever designed, gives you answers. It depends, as always, it depends on what question you ask and what answer you're expecting, right? And you have to interpret the data. So here we have, as clear as crystal, the results from WHI telling us that the Alzheimer's mortality is reduced in women who we followed up for 18 years, whether they were on combination for 5 years or whether they were on continuous estrogens for 7 years. So this is amazing. Now, by the time you've got to Alzheimer's, I am afraid you've got to treat each comorbidity individually. Diabetes on its own, hypertension on its own. I mean, we cannot recommend giving estrogens to a 70, 75-year-old, although we have personally done so in the past.
Great. So
look at vitamin D levels in those cases, because once again, you might say I'm obsessed with vitamin D, but they will have unrecordable levels of vitamin D. These old women with Alzheimer's will have unrecordable levels of vitamin D very often.
Kirolos Tarek is asking you, how does exactly paroxetine helps in menopause symptoms?
Well, it's only for hot flushes, really, isn't it? Paroxetine is an SSRI. I'll just quickly go back to it. Fluoxetine and paroxetine are both SSRIs, selective serotonin receptor inhibitors, and serotonin is thought to be on the pathway of the effect of estrogen metabolites on your neurotransmitters, particularly on your peripheral vasculature. We have done a lot of work on hot flushes, showing that it was not necessarily a central phenomenon, but could also be a peripheral nervous phenomenon, because you find your estrogens are converted to catechoestrogens, to catecholamine-like compounds. So 1/3 of control of your peripheral nervous vasculature is estrogen dependent, and so is your CNS for that matter. The CNS has got its own aromatase there, so it's got its own cholesterol estrogen conversion. It's one of the sites that actually does produce estrogens outside the ovaries. So really, it works through inhibiting serotonin. That's the long and short of it. Your SNRIs work through inhibiting the norepinephrine pathway.
One last question. What about the bioidentical hormones if it's not available in the country where the doctor is practicing?
Yes, well, I mean, this is a marketing strategy, I am afraid. It's an expensive way of doing the same thing. What do you mean by bioidentical? 17-beta estradiol is the most bioidentical estrogen you can hope to have, because that is the main estrogen women have in their lives, and the main estrogen we have. 17-beta estradiol, E2, E1, E2, E3. These are bioidentical. They're all available, pharmacologically. And now we have E4. Those are bioidentical. Anything else is not bioidentical. It's an expensive way of doing the same thing, I'm afraid, okay? And you cannot, as you are all, my good friends, you're all gynecologists as well, you will understand, you cannot titrate the hormone requirements to the minute, because the minute after it will change. Estrogens are constantly, hormones are constantly changing. So just by getting a saliva specimen, for example, and saying, you need such a dose, which we will formulate in our backroom pharmacy, you know, in the old way. I mean, that's not an answer, because your estrogen levels are constantly fluctuating, and one measure you might have in the morning might be different 2 hours later, you know, that's the way it is. So I don't think it's a great loss if you don't have them available. Just use something that's cost effective for your patient. Bearing in mind that the biggest handicap, the biggest drawback I think that estrogens had from a pharmacological point of view was, one, they were very efficacious. I'm not sure a lot of people like something that is really efficacious and not systemic. 2, they had no patent, because the patent had been lost several years before. 3, they are very cheap, and a cheap drug with no patent, which is effective, is not always attractive, you know, for various reasons. But, you know, I still think the combination with serum is a good combination. You know? If pharmaceutical companies want to invest and explore these areas, you know, and carry on refining, there's a lot of scope for work.
Mark,
yes?
To conclude, I have 2 opinions on the issue. Number 1, the menopause and menopause therapy in our region in the Middle East, all the Middle East area, menopause and the treatment is taboo. It's a taboo.
Taboo, I see, okay.
It's a taboo for patients, it's a taboo for doctors.
Yeah.
And in both cases, that taboo is due to lack of knowledge. Yes. In the issue, in the matter. I think, and this is for Abir Annab, and for all my colleagues, I think we should work more on the menopause issue and menopause therapy. We should educate the population, because in this case, we are looking to have a better quality of life for our patients in the society. And number 2, the key strategic issue is when to start HRT for the menopausal woman. And I think the answer is that as early as possible, as early as the post-menopause or the window of, as you name it, we start the therapy, the more success we get and the more quality of life we can give to our patients. Do you agree?
Yes, in Europe here, HRT and menopause is coming up again, is becoming popular again. It is being driven, Michelle, not by people like yourself or myself, although we educate, it's being driven by the women themselves who are demanding a better quality of life. So as the quality of life improves in general, women, of course, want a better quality of life, and they themselves are voting with their feet. They are saying, listen, you know, we've had enough of this. We've lost a whole generation. You know, our mothers, you know, aged prematurely. They had serious psychological problems. Not everybody, of course, because different women react differently. We mustn't go around saying HRT has to be given to everybody, but there is a substantial group of women who actually have severe problems, which are relieved by a very simple treatment. And once your standard of living goes up, once women are better educated, and once women are able to speak for themselves and demand a better quality of life, they are saying, listen, this is a feminist issue, in a way. It's a feminist issue, just like oral contraception was a feminist issue. Why are you depriving us of this with, you know, I won't say fairy tales, because they're not fairy tales, but with improper interpretation of science, because this is what it is. You know, it's an improper interpretation of science. And also, it is an improper interpretation of philosophical argument as well, you know, which can prove. And they are saying, listen, I would rather have a better quality of life in these 5 years, you know, that I'm going through between 50 and 55 or 50 and 59, than maybe extend my life by 6 months. Something that WHO now clearly shows is not true. You're not extending your life by 6 months if you don't take HRT. You're extending it by nothing. or you're actually better, you know? So I mean, and this is where statistics have got to be interpreted correctly. We now have waited patiently from 2002 to 2018. We waited very patiently. Did the breast cancer rates come down? No, they did not. They increased. Did the osteoporotic fractures come down? No, they shot off right through the ceiling, you know? Cardiovascular disease, did that get better? No, it got worse as well, you know? What about skin? What about vaginal dryness? What about happiness during intercourse? Did that get any better?
Yes.
It got worse, you know? So
Yes.
alertness, concentration in your place of work, women politicians increasingly, you know? You know, I'm not saying that you can't be a women politician unless you're an HRT. Of course you can. But if a woman politician is going to find her concentration being affected because of a biological change in her body, then just like, you know, we need spectacles, just like we need, you know, we need tooth implants, which I'm having, then you might want, just like you need thyroid replacement, the argument is you're replacing a natural hormone to somebody who's deficient of it, simply because they are living longer. The truth is, the quality of life is they're living and functioning for longer. It's the function that's important as well. Women are functioning for longer. They're occupying senior positions in families and professions and politics and whatever, and their expectations, quite rightly and justly, are increasing. And it's about time, by the way, that we looked after ourselves, because men, no, I mean, the work in men has been zero. we undergo a menopause. It's a gentle decline, you know? A gentle decline that sort of accelerates. Whereas with women, it's obvious. We have no excuse.
Well, the topic is very hot and interesting. We have so many questions that we cannot take, unfortunately, due to lack of time. However, we promise to organize another webinar on the menopause, and hopefully our guest will be again with us. Mark, you're great, wonderful. I enjoyed your lecture. Thank you very much.
Thank you. Thank you so much, Jeff. Thank you. Sorry we took so long.
No, it's nice.
Okay.
Professor Amr?
Yes, Mark, can you stop sharing the screen, please?
Yes, yes, yes. I have to.
Our next speaker is Dr. Abir Annab. She's from Jordan. She's a consultant, Obs and Gynae, and she's the vice president of the Jordanian Menopause Society. She's going actually to talk about an interesting topic of the HRT subgroups of patients. Dr. Abir, the floor is yours. Please share your screen. There is a share screen at the bottom. And also unmute yourself, please, Dr. Abir. Unmute yourself, Dr. Abir. Nina, can you unmute Dr. Abir, please? Okay, great.
Okay, I'm in. Hello.
Yes.
Hello, Dr. Abir, we can hear you.
Yes, thank you. Good evening to everybody. Thank you for joining me in this menopause update session. Thanks to Eva Pharma for supporting this successful scientific event, and special thanks to Professor Salam, the President of the Egyptian Representative Committee of RCOG, and Professor Michel Abu Abdullah, the Godfather of the Middle East Fertility Society. First, let me express my deep sadness of what had happened in Beirut last week. This horrific disaster made us so mad and sad, but the whole world stood beside Lebanon to help out. Our thoughts and prayers are with the great and resilient people of Lebanon. My lecture for tonight will be about use of HRT in subgroup of patients. My subgroups are for patients with early menopause, patients or women with history of breast cancer, and definitely Dr. Mark will be talking more about this. I'll just share 1 or 2 slides. As we have more patients with the breast cancers, we have more people investigated and women investigated to be carriers of BRCA1 and BRCA2 mutations. And they are wondering what to do for themselves after they discover so, and what kind of risk reducing surgery they will be doing themselves, and what's their position into having an early menopause. So we'll be discussing this hot topic as well. We're going to talk about women with history of thromboembolism, endometriosis, migraine, endometrial hyperplasia, and osteoporosis. Some of the talks has been already elaborated upon by the previous speakers, but it's always nice to have these informations shared and agreed upon. Women with early menopause, some unlucky ladies, around less than 1%, will be having an early menopause with an age less than 40. Either it's induced by surgery or chemotherapy, or spontaneous, as in a primary or secondary premature ovarian insufficiency. These patients suffer more severe vasomotor symptoms, especially with a surgical menopause, when they have a sudden severe symptoms comparing to the gradual decline in a natural menopause with estrogen and progesterone. These patients have a higher risk for sexual dysfunction, neurodegenerative disorders, heart disease, osteoporosis, and they need help. Hormone treatment, if no contraindications, is advised and safe to the age of 50, which is the natural age of menopause. And the WHI study does not apply here. These patients need hormone replacement therapy, balanced diet with added vitamin D and calcium, and exercise. They need also to maintain a good quality of life. It's not only HRT alone, it's the whole lifestyle that has to be changed with exercise, diet, and hormone replacement therapy. These patients usually need a higher than the standard doses of HRT, either the transdermal estradiol or the oral estradiol or the conjugated equine estrogens. Estrogen alone is used if there is no uterus. Whenever there is a uterus, we need to do a protection by adding progesterone for a minimum of 12 days by either a cyclic pattern using micronized progesterone or medroxyprogesterone, or we can have the combined method with lower doses of estrogen and progesterone. Now, the oral contraceptive pills can be used in these patients if there are no contraindications. But with the oral contraceptive pills, we'll be losing the protective role of the hormones over the bones. So the bones, they do better with the hormone replacement therapy than the oral contraceptive pills. Now, patients with history of breast cancer or women with history of breast cancer, given the uncertainty of effect of systemic hormonal treatment on risk of recurrence, these patients should not be offered HRT after the Habits and Stockholm studies done in 1997. And I'm sure we have new studies talking about its role, and it can be used. The hormone can be used in certain type of people of breast cancers. Now, for these patients, the first line treatment for the vasomotor symptoms are the non-hormonal options, either the antidepressants or the anticonvulsants. For these patients, for the genitourinary syndrome in breast cancer survivors, use of low-dose vaginal estrogen is surrounded with controversy. women using low dose vaginal rings or tablets, their serum estrogen level remained at the postmenopausal level. Using now the cream, it might increase it a bit high. So is using a very small amount of hormone replacement therapy and infrequently, does it really do any harm? I don't think so. But you always have to make a decision with the woman and with the oncologist for the safety, especially if they are using aromatase inhibitors, for the safety of using HRT as a local estrogen in the vagina. If it can't be used locally and the oncologist will not approve it for you, then these patients will go back to use the local vaginal lubricants and moisturizers. Now, for the American College of Obstetricians and Gynecologists in March 2016, they said that that data doesn't show an increased risk of cancer recurrence in breast cancer survivors, either on treatment or previous history and finish their treatment, who use vaginal estrogen to relieve urogenital symptoms. So we're relieved. As Dr. Mark said, yes, it can be used. It can be used infrequently, less frequently, but it can be used. Osbifene, which is a third-generation selective estrogen receptor modulator taken orally for genitourinary syndrome of menopause, is contraindicated in breast cancer survivors. Now, this nice hot topic about the BRCA1 and BRCA2 mutations with no history of breast cancer. Now, we have more cases of breast cancer, more patients are tested for BRCA1 and BRCA2, so we have a good number of women with these BRCA1 and BRCA2. And these usually go for risk-reducing hysterectomy, bilateral salpingo-oophorectomy, plus minus mastectomy. So they will be concerned what to do. I will remove my ovaries, but I'm going to have hot flushes. I'm going to have more cardiac disease. I'm going to have a higher chance for fractures, bone fracture. What shall I do? So concerns about HRT might make them change their mind about the risk-reducing surgery. They're deferring it for the sake of not having to take the hormones. So what's the idea of hormone replacement therapy in these patients? In small studies done in 2008 and 11, they showed that short-term use of systemic hormone treatment does not increase breast cancer in BRCA1 and BRCA2 with even intact breasts. In 2011, we have a cohort study in which 1,299 patients of BRCA1 and BRCA2 carriers, they were having intact breast, and they went for protective surgery of bilateral salpingo-oophorectomy. They were followed for 5 years, and they have shown that overall use of hormone treatment was not associated with increased risk of breast cancer, and women with BRCA1 mutation use of systemic hormone treatment was associated even with a reduced risk of breast cancer. So proper counseling is important, and consequences of early menopause is challenging for these patients and their doctors as well. Several observation studies are available, but they are limited by what? By short-term, being observational design, and heterogeneous. And heterogeneous, why? Because we have the BRCA1 mutation are usually hormone receptor negative, while the BRCA2 mutations are usually estrogen and progesterone receptor positive. So hormone treatment might have different effects. So all observational studies done on hormone replacement treatment in risk-reducing bilateral salpingo-oophorectomy are consistent with no increased risk of breast cancer or ovarian cancer, even in women with intact breast. So many reviews done in 2016, 18, and 2019, and they had shown the same results. So long-term powered studies are needed. What we have now, the studies are reassuring of the safety of using the hormone replacement therapy with the woman after proper counseling. For women with history of venous thromboembolism, it's a contraindication for all types of systemic hormonal treatment to use hormone replacement therapy. If it's very important, then you can use HRT plus minus low doses of warfarin, anticoagulant. Now, in French study, which we all love and we all like and we all refer to, it had shown that the transdermal estrogen, okay, it was safely used in patients with history of VTE. So you can go with the transdermal route. Now, for the patients with fibromas and endometriosis, a fibroid might increase the size with hormone replacement therapy, but the symptoms will not be obvious. So it might increase the myoma size, but not the symptoms with HRT use. For endometriosis, you have to be careful. Some studies have shown that the size of the symptoms of endometriosis might go back with the HRT. Now, for patients who had done the surgery, they removed the uterus and the tubes, and they have severe endometriosis and at the same time very bad hot flushes. What we advise for them is the progesterone only pill. Very advised, especially if the large residual volume of endometriotic tissue has been left there, or a combined estrogen and progesterone pill might be used to prevent benign or neoplastic growth of endometriotic implants. For the migraine, HRT may reduce migraines caused by fluctuation in estradiol levels at menopause. Transdermal route is preferred because it has a steady serum level, and try to avoid the sequential HRT to prevent the progesterone-induced cyclic migraines, and try to use the continuous combined patches or transdermal estrogen plus Mirena. And there are no reported interactions between HRT and migraine medications. Now, women with endometrial hyperplasia and approaching menopause, women with endometrial hyperplasia taking a continuous combined preparation who wish to continue HRT should be counseled about continuing HRT. Systemic estrogen only HRT should not be used in women with intact uterus. And you should always report for an abnormal bleeding pattern, and it should be investigated. Now, patients with endometrial hyperplasia on sequential HRT is advised to shift to continuous combined HRT because Cochrane review pointed that there is a reduction in endometrial hyperplasia. So what's the best scenario? Maybe to stop treatment till hyperplasia regress, then treat with continuous combined HRT, or shift to continuous combined HRT without stopping treatment and watch for any abnormal bleeding and the endometrial thickness as well, or use continuous combined HRT as estrogen and the Mirena. Now, duration of treatment depends on many factors. Does she want to continue to use HRT? Is her symptoms and quality of life better? Did the vasomotor symptoms came back after stopping treatment? What are her risks? The cardiovascular risk, the breast cancer risk, and osteoporosis risk. Always these factors and risk factors has to be re-evaluated annually, and then we decide about the benefit and risk balance, and we go in further of the patient benefit. For osteoporosis, using the standard doses of HRT to prevent osteoporosis can prevent and decrease risk fracture, okay? Now, very low doses of estrogen treatment can maintain or improve bone density, but studies on fracture risk are not strong enough. Use of hormone treatment to prevent osteoporosis is indicated when you have hot flushes. Now, if you don't have hot flushes, then treatment of choice is not HRT. Okay, then you might shift them to bisphosphonates. Unless the patients have many side effects and she can't tolerate the bisphosphonates, then I can use hormone replacement therapy for prevention of osteoporosis. And here I go with a lower dose. Duavi is another drug that can be used. It's a combination of conjugated equine estrogen and bacidoxifene, and it has and FDA approval. It has good data now on protection and decreasing fracture on the spine and less on the hip. Now I'm going to have just one or two slides presented to you. This is the revised global consensus statement on menopausal hormonal therapy, published by all the respectable societies of menopause in 2016. The slides that I have shared, I will not go on it, but the ones who I did not share, I will elaborate on it. Menopausal hormone treatment, including tibolone and basiloxifene and the Duavi, is the most effective treatment for vasomotor symptoms, and the benefits always will outweigh the risk initiated within 10 years of menopause and below the age of 60. If there are no contraindications, shift to antidepressants and anticonvulsants. It's not only the hot flushes, it's the quality of life, muscle pain, joint pain, mood changes, sleep disturbances that will be improved with hormone replacement therapy. I'm gonna skip the osteoporosis. Now, if we have a vulvovaginal atrophy or the genitourinary syndrome of menopause, the low-dose estrogen therapy is preferred in these patients, and osmorphine is another also a choice. Now, RCTs and observational study has shown that using estrogen alone replacement therapy will decrease myocardial infarction and all-cause mortality. Now, if you add the progesterone, the effect will be less. Cardioprotective effect is less. Okay, thromboembolism, so we talked about it. Breast cancer, I'm gonna leave it for Dr. Mark. And menopausal hormonal treatment initiated early in menopause, no effect on cognitive function, but it might has, in some studies, small studies, prevent Alzheimer's disease later in life if started early and within 10 years of menopause and below the age of 60. If started late, cognition will be worse and there is increased risk of dementia. And it will improve also, hormonal replacement therapy will improve depression and anxiety, but it's not the first line of treatment for these cases. It's always the antidepressants. Now, the type and route of administration of menopausal treatment should be consistent with the treatment goals, patient preference, and safety issue, and should be individualized. Dosage should be titrated to the lowest appropriate and most effective dose. Duration of treatment should be consistent with the goals of the individual and benefit risks profile that has to be reassessed annually. And this is important because we are seeing more patients suffering with vasomotor symptoms for longer years. And the use of custom compounded therapy is not recommended because of the lack of regulation, safety, impurities, and the lack of standardization. And current data, safety data does not support the use of systemic hormonal treatment in breast cancer survivors, although discussions in selected women in conjunction with the oncologist may occur for compelling reasons that non-hormonal treatment is not doing the job and she's really suffering and is not successful, then she might be using small doses of HRT. And thank you very much. I tried to be within my 20 minutes time. Thank you very much.
Thank you, Dr. Abir, for this excellent presentation. I think we have a few questions. I think there is a question from Dr. Tasneem Hussain asking about HRT in patients with BIRAD 2 or 3 findings in breast ultrasound. We know that BIRAD is usually benign 100%. In BIRAD 3, there is risk of 2% malignancy. So what
now,
would you do?
If I got the question right, if you have like a fibrocystic changes in the breast or you have a fibroadenoma, what's the role of hormone replacement therapy in these patients?
Okay, correct, yes.
This was the question. Definitely Dr. Mark will be elaborating on this in his lecture, but,
okay.
I don't think there are contraindications of using hormone replacement therapy with the fibroadenoma, as long as the patient is followed every 6 months by ultrasound and annually by mammogram study.
Okay, there is a question from Dr. Tufail. What's the most likely management for a menopausal woman undergoing chemotherapy due to breast cancer still having menopausal symptoms?
Now, these patients, if they are under hormonal treatment, definitely I'm not going to give HRT. I'm going to give antidepressants, okay? And I'm going to, if it doesn't work, go to the anticonvulsants. I don't think anybody, especially if they are estrogen receptor positive and progesterone receptor positive, anybody will be able or be brave enough to give hormone replacement therapy. And if you say yes, the oncologist will tell her, don't take the treatment. Now, if it's a triple negative, then it's a different story. And I'm sure Dr. Mark will be elaborating on this more than, but definitely the oncologist will not agree on giving HRT for patients having breast cancer and under chemotherapy now.
Okay, there is another question from Dr. Tasneem Hussain. That it's said that Livial should not be started before completing 1 year of menopause. Would you agree about this?
Yes. What happens sometimes, really, after you lose your period, we have to have one whole year before we say that we go into menopause. During this time, sometimes we have irregular spotting or bleeding. If we start Livial and she started to spot or bleed, then we might be, we might be saying Livial is the cause. So go into menopause, have an atrophic endometrium, be sure that she's in postmenopausal status, then use Livial. Because if you have irregular spotting, you'll be blaming the Livial as a cause and you'll be stopping it for no reason. That's why it was advised to have 1 year before postmenopausal before you start Livial.
And can you start HRT in women with vasomotor symptoms before the menopause?
Oh yes. Oh yes, definitely. We have some patients, suffering all the symptoms and they have regular cycles, but she comes to you at 45, 46 years of age. She has regular cycles, but she has all the symptoms there. So definitely these patients, after proper counseling and investigation and doing the proper, mammogram for her, definitely we're going to start hormone replacement therapy and she will have a better quality of life. And she'll be very thankful to you and happy.
There's also a question from Dr. Nabil Nathan. He's the UK consultant. I haven't seen him for 30 years from now, so that's good actually to see his name. He's saying that Mirena protects the endometrial cancer. Do you use other types of hormonal intrauterine devices?
In Jordan, we don't have the jade. We don't have the other smaller doses of the systemic, the local devices. It's the Mirena. We only have the Mirena intrauterine device. Now in Europe and in USA, there is the lower dose. It's called the jade. Okay, and it has a lower doses of levonorgestrel, but in Jordan, we only have the Mirena. Now, you can have a local progesterone like a Crinone, and you can have a local progesterone as, Cyclogest or Utrogestan as the progesterone arm of the HRT when you have a uterus there, and you want to protect the endometrium.
Okay, there is also a question is, when is the oncologist asked for their opinion in terms of physical-legal issues? When should we ask them about hormone replacement, or we should not, or?
You mean in breast cancer survivors? Or only in breast cancer survivors, or if you have ovarian cancer, or if you have uterine cancer, or you have cervical cancer? Usually in cervical cancer, HRT can be used. Most of the cases of ovarian cancer, it can be used unless it is endometrioid. And there is some talking about serous adenocarcinoma, then it's a relative contraindications. For the uterine cancer, usually if it is stage 1A, grade 1, then you can have a hormone replacement therapy. For the breast cancer, you have to have the approval of the oncologist, and it depends on the estrogen receptor if they're positive or negative, and if she had finished her treatment. Because during treatment with the chemotherapy, I don't think anybody will be able to give hormone replacement therapy.
There is a question from Dr. Laila Al-Arifi saying, how would you evaluate the severity of hot flushes?
It depends how the patient how much the patient is complaining, the quality of life, how frequent does she have it, how much it is interfering with her daily activity, and if it's causing other symptoms like sleep disturbances, insomnia, and affecting her activity, productivity, reaction, and the interaction with the people. People might be telling her that she's having something going on, and go to check with her doctor what's happening with her hormones. So it will be obvious to us as from the patients and their complaints about the severity. Some of them, they will tell you, I just feel it once a day and I'm fine, I'm not bothered, I don't want any hormone replacement therapy. Some other of patients will be having hot flushes every 1 hour in 24 hours, day and night. So these are the more sufferers of the vasomotor symptoms.
Thank you, Dr. Abir, very much really for this excellent presentation. I think for the sake of the time, if you don't mind, if you can answer some of the questions directly in the question Q&A section, please. And now we'll come back to Professor Mark Brinkat, who is going actually to talk about breast cancer controversy. Can you stop sharing the screen, Dr. Abir, and give the floor to Prof. Mark?
And help me share the screen. Okay. Let's see what's going to happen. Oh, look, my heaven. Good. Dr. Abir, thank you so much. It was a very nice lecture. Let's see. Okay, can you see it? Can you see it? It's...
Yes, we can see it.
Okay, very good. So I think we'll start now. Thank you so much. This has been very pleasant listening to all of you. I'm going to limit most of this lecture to the estrogen receptor positive breast cancers. So let us start with this. The statement HRT and breast cancer. What comes to mind straight away when you think about this? Of course, everything comes to mind, WHI clearly says that HRT causes breast cancer. Does it? No, it does not. It does not. Does estrogen cause breast cancer? Well, 50 years ago, estrogen was used as treatment for breast cancer. Biologically, estrogens actually, E17-beta-estradiol, actually causes apoptosis of breast cancer cells, of estrogen receptor positive breast cancer cells. And the early trials of tamoxifen were done against cell lines which were treated with estradiol. So this is really interesting. Now, of course, tamoxifen has become the gold standard, but for many years, estradiol was used as an anti-breast cancer drug. And if any of you are interested, you can read Harry-Ann Koenig's chapter on this. And this is it. You have to remember the other problem is that there are some extra ovarian tissues that do produce estrogens of various sorts. And one of the key places where estrogens are produced is the breast, and the other one is the brain. So the amount of estrogens that you've got in a breast is much in a postmenopausal breast is actually much higher than you'd get from your average HRT. So these are some misconceptions we need to get away from. Now, let's start and say, why is this alarming? Of course, breast cancer is alarming. Breast cancer is responsible for 15% of all cancers in women. 26% is lung and bronchi cancers. But if you look at this other studies, see that you find that breast in women, the risk of developing a breast cancer in women is 1 in 8. So you've got this background, 1 in 8. And the older you are, the higher your risk of developing a breast cancer. So an older woman would obviously get a higher incidence, a higher chance of having had a lifetime risk of breast cancer. And what's interesting is that many women get breast cancer when they are postmenopausal, when they are long postmenopausal. How do you explain this? How do you explain the fact that most breast cancers occur in women who are postmenopausal and therefore have no ovarian estradiol or estrogens at all. And you can see all the others here, ovary, 1 in 72, very, very high, high mortality. But this is very much on our radar, breast cancer. It's common. So once you've had a breast cancer, what are your options? Well, you might want to follow up your breast cancer. You might, okay, let me rephrase this. Should you be a woman at high risk? And a woman at high risk can now be determined by various scores. One model that's used is a Gale score, and you might want to do something about it. So now we have identified some women who are high risk, and I'm sorry I'm being very vague about this, but there is a Gale score which gives you quite a good score. On the other hand, there are genetic markers like BRCA1, BRCA2, but they only account for about 5% of all breast cancers. But certainly, if a woman is identified as being high risk from her history mostly, and family history as well, then follow-up might be an option. But today, we can have some form of chemo prevention, effective chemo prevention. We can have a prophylactic mastectomy, and there can be also a prophylactic oophorectomy in addition for these BRCA1 and BRCA2s especially. But chemo prevention is quite a novel concept. What about lifestyle changes? Some people always talk about these lifestyle changes. Increase your vegetables, increase your fruit and fiber, make sure you are not overweight. Obesity, we've heard Boris Johnson tell us now that this is a very big problem, and only the Maltese have got an excess of obesity ahead of the British, it seems. Some Maltese weren't very happy with that. Smoking has also been associated with an increase in breast cancer, but of course this is associated with an increase of virtually every other cancer. Reduction of alcohol intake. Alcohol intake has been associated with an increase in breast cancer, and these are associations. 1 glass of wine is about the equivalent of risk of the worst risk you can have with HRT. And prolonged lactation, for some reason or other, this is associated with a reduction in breast cancer. So if you want to lactate for longer, then you are with a lesser chance of having a breast cancer. So all these are ways you can do it. Chemo prevention, the whole idea, if it's primary, is to prevent cancer in healthy women. And really, it's prevention of cancer not just in healthy women, but you can also target women who are at risk. Secondary prevention, so if a woman has had a pre-malignant lesion, you've got to try and avoid this developing into a proper breast cancer. And I have to quickly tell you that breast cancer is a number of diseases, not just one. But for the purposes of this lecture, we are dividing breast cancer into estrogen receptor positive and estrogen receptor negative, just for the sake of simplicity, otherwise we'll never end. And tertiary is the prevention of a secondary cancer of women having had a previous cancer. Now, we talk about tamoxifen, which was the first form of chemo prevention that was identified, and probably Hassan, Sarah, my good friend, Professor Hassan, will remember that when we were at King's, there was a Professor Baum there, who was Professor of Surgery, also Dean, and he was a pioneer in the studies that showed that tamoxifen was of use in breast cancer and of use in preventing secondary recurrence in people who had a breast cancer. So this was a revolutionary drug compared to, as I said, in cell biology studies with estrogen. But tamoxifen is a selective estrogen receptor modulator. We discussed earlier how estrogens have been highly conserved throughout evolution. There are estrogen-like molecules. These receptors are easily targeted by a large number of molecules, and SERMs can have different things. For example, in the case of tamoxifen, it blocks estrogen activity on the estrogen, but it's agonistic when it comes to uterus, bone, and liver. We know that you can get endometrial thickness, even endometrial cancer with tamoxifen. You get prevention of osteoporosis in bones and estrogen-like effects on the liver. But it's antagonistic in breast and breast cancer tissue. Tamoxifen, on the other hand, is also antagonistic in breast, but it's antagonistic in uterine tissue, as is bezoxifene, but it's agonistic on the bone. Tamoxifen is. And don't forget their cousin clomiphene, which we use extensively in infertility, is actually a SERMs as well. Bezoxifene is another third-generation SERMs here. These are the successful ones. So looking at Professor Baum's original work, part of it, we can see that if you had 5 years of tamoxifen you did reduce your incidence of recurrence of breast cancer by 11.8%. This was quite good and also very highly statistically significant. If you had, on the other hand, this recurrence, mortality also was reduced by 9.2%. We can see these are significant improvements. This is just by using the modality of tamoxifen on its own. So using tamoxifen on its own, you had a reduction in recurrence rate and a reduction in mortality. This is a form of chemo prevention. Now, what about in the instance of invasive and non-invasive breast cancer? Here is LCIS here, lobular carcinoma in situ. And you can see there's a reduction of 37% in relative risk in women who are on tamoxifen compared to women who are on placebo, whereas with an invasive cancer here, it's a different study, there was a further reduction of up to 43% in invasive cancer. So you can see here, these are women who are being tried. These are high-risk women. These are women who have not had a breast cancer. They are regarded as high risk and they've been followed up for a number of years. The ones who have, so this is primary prevention, not secondary, okay? So primary prevention, 43% less. This is LCIS, 37% less. Tamoxifen for the first time was able to show a reduction. If you were to look at the estrogen receptor positive ones, because these breast cancers are mixed, estrogen receptor positive ones specifically had as much as a 62% reduction in breast cancer in these high-risk breast cancer women. Now you look at the rate here was not changed at all in women who are ER receptor negative. So the tamoxifen was reducing specifically the risk in those women who are going to go on and get estrogen receptor positive breast cancers. So following this idea, raloxifene came about. Now, raloxifene was used as an anti-osteoporotic drug as an alternative to HRT. It was developed with the SERMs, and the whole idea was to introduce something that had no estrogen activity on the breast and was therefore regarded to be safe. But not only did that happen, yes, vertebral fractures were reduced, hip fractures were reduced, but after 4 years of the small trial, a surprising 72% reduction in breast cancers were observed. Now, you've got to realize, please, that these are not big numbers. Although we say 72%, the numbers are not very big. But nevertheless, this made people stand up and pay attention. And in particular, these were the ER-positive breast cancers that showed this huge difference when compared to placebo. And you could see that in this first study, as many as 84% difference in breast cancer incidence between placebo and raloxifene was demonstrated, whereas ER-negative, there was no change. There was a thrombosis in this group. The thrombosis rate was threefold, which is very similar to HRT. So then a cardiovascular study was carried out, and then finally a breast cancer study was carried out specifically, and all these were the same patients that were followed up for longer and longer, with the end result being that there was, after about 8 years of study, there was a 55% reduction in ER positive in the overall group. So this gave some indication that it was possible in using, when one was using treatment that was targeted for menopausal patients, it was possible to actually reduce incidence of breast cancer, to go right the opposite way to what was thought possible before. And so, and this was what was amazing here. In treating symptoms associated with the menopause, we were actually achieving a reduction in breast cancer. So, ERC-RCOG guidance came along 2013 after a lot of work. I'm skipping a lot here. I'm skipping the studies that were done on aromatase inhibitors because they're not present in this lecture. And we were part of the tamoxifen study here, looking at the reduction of incidence in breast cancer in high-risk women, called the IBIS-1. There were two studies. One was IBIS-1, one was IBIS-2. And the idea here was to see if we could actually prevent breast cancer. IBIS was both were published in Lancet. We were one of the centers, and the conclusion was this, that if you're 25 years or older and at risk of breast cancer, then you ought to take tamoxifen for an extra 5 years. Your risk of breast cancer, of invasive breast cancer, was reduced to an RR ratio of 1.66. That's 66%. and likewise for LCIS. For some reason or other, of course, tamoxifen like HRT is not recommended or is to be used with caution in women with a history of DVT, pulmonary emboli, or have had strokes in the past. And at the time, it was not recommended in combination with HRT, but as you have seen, we do have bezodoxifene and HRT in combination. And although this is a medical legal requirement, nowadays there is a lot of interest in combining ACERMs with small doses of HRT. And follow-up, of course, is follow-up. Okay, so guidelines for raloxifene are similar for 5 years in high-risk patients. Similar results are a risk of 1.66%. Can be used in women with osteoporosis. Certainly, there is no restriction because raloxifene was originally licensed as an anti-osteoporosis drug. So you can carry on with raloxifene. So this is interesting because you might have a woman who's been on tamoxifen for 5 years, who's a breast cancer survivor, and you might want to be able to give her an option for her osteoporosis. And raloxifene certainly is a very good option because you are here killing 2 birds with 1 stone. Wishing to remind you that the 2018 guidelines suggest that breast cancer survivors can have an extra 5 years of tamoxifen if they are premenopausal, and if they're postmenopausal, they have an extra 5 years of aromatase inhibitor. So the treatment recommendations for breast cancer survivors have now gone from 5 years to 10 years of treatment, and the results are better. They're cumulatively better. Once again, not to be used in thrombosis. So now we come to our controversial WHI. So this is an estrogen plus a progestin trial, and the trial was really designed as a trial that was hoping to demonstrate a reduction in cardiovascular disease. It was nothing to do with menopause, it was nothing to do with osteoporosis, even less to do with breast cancer. The trial was designed on the hypothesis that if women were treated with HRT, they would have a reduction in cardiovascular events, knowing that cardiovascular events in postmenopausal women have got a much higher mortality, indeed, than they have in men. So the drug of choice was 0.625 conjugated estrogen, by then having its 60th birthday in the United States, extremely popular. And they added 2.5 milligrams of medroxyprogesterone acetate, which we knew about, but was not very much used in Europe. And there was a daily placebo pill. Now, there were a number of requirements here. You had to not have hot flushes. So it was blinded. You had to be of a certain age, a certain number of years postmenopausal. And the end result was that your average patient was in her 60s, tended to be overweight, and had other problems, which are not the sort of women, I emphasize, that we treat for menopause. We treat normally women who are between 50 and 55, or maybe 59. We do not treat 60-year-olds de novo with HRT. So women who had a hysterectomy were put on the estrogen-only part of the trial, which I have to remind you are conjugate estrogens, not exactly estrogen, but a combination of estrogens. And there's some suggestion that the combination of estrogens with in Premarin is what makes it work. Every time we try to find with the active ingredient in conjugate estrogens, that's never been quite so successful. So you have to accept conjugate estrogens as they are, a nice mishmash of estrogens that have passed, that have been extracted from a pregnant mare's urine. But it works, and it's got 70 years history behind it. Okay, versus a daily placebo pill. Okay, writing group. 2 major publications, one from JAMA 2002, and this is where the bombshell landed, because in 2002 we had the release of the paper pre-publication, so we really didn't know what hit us. We had newspapers reporting this big disaster, and we really didn't know what hit us. And then this was followed up by 2004, and since then we've had regular papers coming out from JAMA right up to July 28th of this year, 2020, which Nick Panay showed you earlier. So this has been coming out in installments, and every installment seems to reinforce the idea that the news is, after all, not as bad as was initially reported in the newspapers. But this led to a whole generation of women missing out. So these newspapers were calling us names to begin with, then started calling us names about 2 years ago, because a whole generation of women had been deprived of their estrogens. The women were justifiably angry. Now what happened with the estrogen-only arm? The estrogen-only arm went on for 7 years, because even as early as 2002, there was no problem there. estrogen-only arm showed originally that there was, in fact, a reduction in breast cancer. It's not an increase, but a reduction. I will quickly give you the numbers that we were talking about. So the numbers we were talking about, as opposed to percentages, sometimes it's very important to see that you have the numbers. And the numbers were these. There were 8 extra cases of breast cancer in 10,000 women, 7 extra cases of heart attacks in 10,000 women, 8 extra cases of stroke in 10,000 women compared to placebo in the estrogen, medroxyprogesterone arm. And because of these numbers of 8, 7, and 8 out of 10,000 women, the estrogen progesterone only arm was stopped. There was no obvious benefit in cardiovascular disease. There were 7 extra cases of heart attacks and 8 extra cases of stroke. And the study was therefore stopped at 5 years, but the patients were followed up. With the estrogen only arm, however, there was a 20% reduction in breast cancer rate. So the estrogen only arm kept on going for another 7 years, and the study showed, the study did not demonstrate a benefit from cardiovascular disease. Not surprisingly, these women were obese, 60-year-old women on average, and this was therefore abandoned. But what immediately was obvious was that the CEE alone was safer regarding breast cancer than combined estrogen plus progestogen. And the progestogen is important. So in 2004, we had similar data coming out, which by then showed that the premarin-only arm, this was 2004, had a 23% decrease in breast cancer. So this was beginning to look a bit better, promising. CEE showing a 23% reduction in breast cancer, with that arm having had at least 7 years worth of estrogens. So what was going on? Are we going to say conjugated equine estrogen is actually chemoprotective from breast cancer? And yes, it does seem so that the combination of CEE does prevent breast cancer by 23%, and this figure went up to 45% by 2017. You can see some more interventions, and finally the paper in 2017, which was astounding because here they were looking at all-cause mortality in the use of CE and MPA, CE and placebo. These were patients followed up 7 years, and placebo. And in fact, if you look at the mortality, there was absolutely no difference. So the taking of HRT, both in combination and alone, resulted in no significant difference in mortality after 18 years. So much for the doom scenarios that we're seeing in the year 2002. Here you go. Look at that. This is another way of showing it. And even if you look at the cancer, the instance of overall cancer, with some cancers showing a reduction in rates, such as colonic and breast cancer with CE, for example, you see that even the overall cancer rate was no different whether they had intervention or placebo. But you have to remember that the whole purpose of HRT is really not to prevent cancer, not to prevent death, because we all have to die, not to prevent cardiovascular disease. The whole idea of HRT is to improve your quality of life in your early 50s, mostly, and then hopefully prevent osteoporosis later on. So what if you looked at cohorts? So JAMA themselves decided to look at cohorts. What was it like if you started HRT between 50 and 59, compared to if you started HRT between 60 and 69, for example, or 70 and 79? So they divided them into 10-year deciles, we call them 10-year groups. And you can see that the group that we are mostly, I mean, there were no differences really in 60, 69, 70, 79, but the group that we are mostly interested in, this window of opportunity, this group of women who are normally looked after by gynecologists and put on HRT because of their short-term symptoms, here we find that this is of breast cancer. Your risk ratio here is 1.44, which essentially means, essentially means that you have got a relative risk ratio. Here, the relative risk, is 1.44, which essentially means you've got a 54% less chance, 56% chance less of getting a breast cancer. And this was statistically, let me rephrase this again, Here, there was a higher risk, which was not significant. If you're on PA, you had a higher risk of developing a breast cancer but it was not statistically significant. If you were on CE alone, your relative risk was 0.55, meaning you had a 45% chance less of getting breast cancer. Why was this not given that much importance? And the reason is because we are looking at relative risk, and this is a percentage which is a small incidence when it comes to numerical numbers compared to the overall number of cases. Let me give you an example. If you have, for example, 4 out of 10, that's a 40% incidence. 4 out of 10 and maybe 8 out of 10, that's a relative risk of 2. 8 out of 10, 4 out of 10. If you have 8 out of 100 and 4 out of 100, that's still a relative risk of 2. If you have 4 out of 1,000, 8 out of 1,000, that's still a relative risk of 2. But the significance of that information is very, very, very different. So this is why we have to be careful when we talk about relative risks. And there was a heterogeneity between risk estimates. The results were not pooled. They knew they were giving relative risks here for a number of different entities. There was no biologically plausible data. And I have to put it to you that certainly the relative risk for the combination is very low. And although we are very happy to see a 45% reduction in relative risk for CEE, this too probably is not significant in the long-term story of the overall story, in the big story. But anyway, it is useful and it's something to think about. Colorectal cancer here, we can see between groups is not different. However, we were very happy that this did reach significance. But this also was very interesting. Look at the 50-59 year group, you can see the different the mortality rates. And if you start HRT early enough, then yes, you're going to have a big difference in all-cause mortality, and you're going to have a difference in other mortality. I mean, this keeps on going down and further down when you see the actual individual conditions such as Alzheimer's. Alzheimer's reaches significance. So all these to the left mean you've got less of a chance of dying if you've been on HRT, and less of a chance of dying by a particular age, 18 years post-treatment, because as I said before, everybody dies. But there are some, for example, you look at CE alone here, you get significant differences. Pool tries to get significant differences. So, what are we saying? You need to have a biologically plausible story to have causation. There's a big article on climacteric, this was climacteric, by John Stevenson and Farmer. And being Alexandra, I came up with this quote of logic. I'm sure it was in Greek. And say correlation does not imply causation. So just because something correlates doesn't mean it causes it because of it. And even more, association does not imply causation. And this is a logical fallacy in those who studied logic, like myself in philosophy. With this, therefore, because of this, does not hold. This is illogical. Might be true, but you've got to show biological plausibility. In Latin, cum hoc ergo propter hoc, we say. I'm sure this is the Greek equivalent, which predates it. And this is very important. The second logical fallacy is after this, then because of this. Post hoc ergo propter hoc here. The conclusion might not be wrong, hence an understanding of sets exemplar is necessary, but you cannot say that this happened after this, therefore it's because of it. These are two logical fallacies that we must be careful and that have been present from the very first WHI study. The idea that the small correlation implied causation. This was completely wrong. In fact, if you look at the then director of the FDA, because of this, he said, actually I quote, if the relative risk isn't at least 3 or 4, forget it. And this is what they mean when they say, forget it, relative risk on its own gives you a pointer and you go and look for biological plausibility. If the biological plausibility says estradiol causes an estradiol in ER-positive breast cancer cells, that is the biological plausibility. You cannot come around and say that 2 cases out of 10,000 extra is necessarily going to a cause of breast cancer. So this is very dangerous. Also, your aromatase activity in your breast gives you estrogen levels which are much, much higher than you get with HRT. So a lot of women have been deprived from estrogens, and in consequence, we had a lot of problems as women were aging, and they were not aging as well as they could otherwise have been. Another different study here, you can look at this. This is the French study showing differences between different progesterones. So we thought it wasn't the progestogen after all. And there are clear differences between progestogens. Here is the medroxyprogesterone acetate, which gives a relative risk of 1.69. And then here, of course, it covers 100,000 women with dihydrogesterone. And we spoke about dihydrogesterone earlier, saying how similar it was to natural estrogen. Here, in the French, have got utrogestin, of course, micronized progesterone. The risk is the same as with estradiol alone, it's 1 at 1.6. In fact, these results with dihydrogesterone and natural progesterone are actually better than estradiol alone. But once again, look at the confidence intervals here, and really there's no big difference between these three. Something to be taken notice of here, and certainly we nowadays do not use these sort of progestogens anymore. But dihydrogesterone, like inflammasome, is very popular, and you can see that the relative risk is virtually 1. From a breast cancer point of view, from a relief of symptom point of view, of course, you've got your streets ahead, like we said in our first lecture. Another paper, and now we've got the last million women study, which was actually just published in 2019, really a rehash of the old data. It's the same data reanalyzed. Nick Penney went through it quite clearly. He said there was a number of estrogens, number of progestogens. Everything was thrown into the same machine, if you like. Trying to remember what it is, the same blender, and they got this sort of statistics here saying that non-users had 60 over 1,000. Estradiol, if you used estradiol, you would have a breast cancer incidence of 5 patients per 1,000 extra. With intermittent progesterone, they hardly had any. It doesn't even say. It says progesterone, even progestogen. Progestogen, it should be a bit more. And if you had daily progestogen, not progesterone, as they said, I had 83 per 1,000. So these are numbers. They're not significantly different, but of course there was a lot of alarm with this WHI, with this million woman rehash from Valerie Barral. Once again, no biology, just number churning. So then there were a number of statements from the International Menopause Society, data collected from studies preceding first publication of WHI. Those preparations don't exist anymore. We don't use them. Also, the MHC regimens were different from those currently used. We did learn something from WHI. We modified our preparations. The relation between obesity and breast cancer is noted. By the way, if you look at numbers, obesity was by far a higher risk than any of the HRT was. And the potential breast cancer risk is only one component of the benefit, because we do actually give HRT for the benefit of individuals and for their symptom severity and potential beneficial effects on bone and cardiovascular health if used early. So the benefits far away outweigh the potential theoretical risks. Summary of the British Menopause Society, they looked at 58 studies. These are 58 studies, of which 24 studies were prospective, mishmashing your blender, as I said. This increase in breast cancer incidence, but no information on mortality. And once again, the preparations are not used, basically. And dihydrogesterone comes out always as being the best progesterone anyway. So, but the adequate numbers in micronized progesterone to draw a conclusion. And the French are the only ones who use micronized progesterone in significant quantities to be able to give us a proper conclusion on the use of that progesterone in combination with estrogens. So other comments, they said the extension of that, they would have said extension of the million women study, a meta-analysis. Meta-analysis is a blender of heterogeneous preparations. This actually gives you both the first and second logical fallacy, gives possibility of the first and second logical fallacy arising. And there are differences in study protocols, very difficult to know what's going on there. And the BMS highlights that the latest data of a proper randomized control trial is the JAMA study I just showed you from 2018. The 2020 one, which I'm not showing you today, is just a breast cancer arm of it, which has gone on for a bit longer, which is exactly the same. And I think we should really take this JAMA article of 2018 as our key publication in this field. We had a randomized control trial found there was no significant increase in breast cancer incidence and really in mortality. Obesity is an overwhelming cause of breast cancer. We know that obesity is quite common with age, and these findings are given nice guidelines. The increase numerically was very small, even in the worst possible scenario, and the risk is comparable with other lifestyle factors such as alcohol intake and obesity. So if you've got alcohol intake and obesity, you've got by far a much higher risk of breast cancer, particularly if you've not had children, for example. Okay, these are other, we give HRT to improve hot flushes control, quality of life, bone cardiovascular benefits. This is a bit repetitive, but it's what we use HRT for. People sometimes lose the objective of the use of HRT. HRT is given to improve mostly short-term symptoms with possibly long-term effect on bone mostly. But now we know cardiovascular and Alzheimer's. So what about HRT and breast cancer? Which estrogen should we use? We can select cleverly nowadays. We can select conjugated equine estrogens if you can find them, because they've suddenly disappeared off the market. We can find 17 beta-estradiol valerate, very common, 17 beta-estradiol, E2, and estetrol. There are studies with estetrol, interestingly enough, showing that it reduces the incidence of breast cancer at the same rate as tamoxifen does. Estetrol is a weak estrogen produced by the fetal liver, now obviously produced in labs, and it's Harry and Koenig's baby. I mean, it's been around for a very long time, but even the fact that the baby, a fetus, produces in large amounts means that it probably acts as a SERM. It blocks the effects of estradiol, maternal estradiol, on the baby. Can you imagine what the effect of these huge levels of estradiol would be on the baby if there wasn't estetrol blocking that effect? So it's a SERMs. All have different risk attributions to breast cancer, and this depends on period of treatment, management, age, patient, and other variables. So we are talking about women who are treated at the age of 50 and 55, 50, 59, and if one starts on treatment, you then select, assess, follow up carefully, and individualize treatment. We do not treat 65-year-olds de novo anyway. Sometimes we carry on if they are properly selected. Okay, so what about progesterones and progestins? Please distinguish between a progestin, which is a laboratory-based progesterone-like compound, but it is not natural progesterone. Natural progesterone is very poorly absorbed from the stomach, and therefore the pharmacologists have long resorted to producing progestogens, but they come in different families. Now we've got migrated progesterone or vaginal progesterone, which enables us to use natural progesterone, but it's really has got very little indications in use for HRT, where you need a proper cycle control. These are of use mostly in infertility. There are androgenic progestogens, medroxyprogesterone acetate. There is dydrogesterone, which, as I said, is a stereoisomer of natural progesterone, and you can choose. And definitely, in our books anyway, the dydrogesterone and natural progesterone have come out to be the best. But this last thing, if there is no uterus, you don't need to use any progesterone, and you don't need to use a progestogen because there's no endometrium and no risk of endometrial hyperplasia. So there is no problem. And one of the problems with progestogens, by the way, is not so much breast cancer, but is the fact that you get PMT-like symptoms, bloatedness, water retention, and so on. So, conclusion, the overall evidence points to accumulation of risks of breast cancer through living, through your life course. So the older you are, the more at risk you are. And you can actually calculate through a Gale score what that risk is going to be like. Most of your life, or 30% of an average woman's life, is lived in a post-menopausal state without any estrogens. So most of breast cancers will occur after a woman has not had estrogens for a very, very long time. Hormone therapy may offer a potential to inhibit final stages of progression to cancer. So the prevention is greatest amongst those with high estrogen levels. So if you give proper estrogen, CE, for example, you might even inhibit the final stages of progression and get a better type of breast cancer, a more organized, less aggressive type of breast cancer, which gives us a better chance to treat. And the lifestyle, of course, contributes to a cumulative risk. And therefore, I think this is the overwhelming contribution to cumulative risk is how you live, socioeconomic state, number of children, whether you lactate or not. And it's no surprise, for example, that in societies with higher numbers of children, breast cancer rates are lower. So thank you very much. Thank you very much. I can now open this lecture to the floor. I'll stop share, shall I?
Good.
Hello.
Hello, thank
Yes.
you, Mark, very much for the presentation. And I think because of the time, we can have one or two questions. Michelle, would you like to take these questions, please?
Well, I have here from Hayat Sharaf. What is the best treatment regimen for patient? Well, this we have answered this, Alzheimer, etc. And what about bioidentical hormones and the availability? If they are not available, what the doctor would choose instead?
Keeps on coming up. I mean, even Dr. Aber answers it. Bioidentical hormones really are just compounded. They are not. They don't have any form of validation, and really it's an expensive way of getting normal HRT. Normal HRT is freely available. They are, but the name bioidentical is a marketing ploy, really. Let's face it, because 17-beta-estradiol is bioidentical. It's a natural hormone. E4 is a natural hormone. E1 is a natural hormone. E2 is a natural hormone. Yeah, and so really, if they're not available, just use. I wouldn't even go for them first line. Use normal HRT. Having a compounded bioidentical preparation, I mean, it's just a marketing ploy. And anyway, your requirements fluctuate so much that you might as well just go for a readily available, cheaper, effective product that has been tried and tested, proper studies have been undertaken, then go for something that's relatively unknown. You might as well go for phytoestrogens if that's the case.
I have a question from Dr. Omar Mashar, and he's asking, should we prescribe HRT to all postmenopausal women, or only if they are symptomatic?
Yes.
And I would rewrite the question. Yeah. Should we offer HRT to our perimenopausal woman?
Well, yes, as Dr. said, when your hormones are fluctuating in your premenopausal period, you can get symptoms as well. In gynecology, we were one of the first to identify the change in hormone levels, a fluctuation as being important, as opposed to an absolute level. And I think it's very important in this field to individualize your patients, very important. The one lesson we learned from WHI was not to go around treating HRT as if you are dishing out, chocolates to children, basically. There's not a one size that fits all. I think we should have some selection bias and go by the proper history. As always, we teach our students history and examination. History examination are very important, and investigations, okay? So it's one thing if you're dealing with somebody who's perimenopausal, who's got hot flushes and irregular periods. It's another issue if you're dealing with somebody who's immediately postmenopausal with hot flushes, sweats, anxiety, flutter, psychological problems, or with somebody with high risk of osteoporosis, for example. Hot flushes, you get away with a very low dose of estrogens. Osteoporosis, low bone mass, you need a higher dose of estrogens. You will not get away with the tiny dose of estrogens if you want to improve somebody's bone mass. We have known now for a good 30 years that it is possible to increase bone mass with estrogens. It is not just a question of stopping the bone loss. It is actually possible to increase bone mass. If I work on skin, it is possible to increase skin collagen. So you can reverse some of the damage that is done from a hypoestrogenic state. And this is why you need to tailor your treatment depending on the individual. If there's a uterus, use a Mirena coil or use a progestogen, because you need to have adequate cycle control and you need to have endometrial shedding. It is an art and it is a science.
I have a question from Dr. Wissam Al-Masharawi. What is the effect of HRT on cervical tissue? Does it increase the risk of cancer?
Okay,
and
no.
I can use HRT if the patient...
No, absolutely not. Cervical cancer is not an estrogen sensitive cancer. It's not an estrogen responsive cancer. It is actually, as we all know, a viral induced cancer nowadays. So there's no effect from a cancer point of view. From a tissue point of view, however, you can improve your cervical mucus, you can improve your cervical epithelium, you can improve your cervical length, you can improve your cervical collagen. And as you know, a postmenopausal uterus that's 5 years, 10 years postmenopausal is much shorter. It's got a longer cervical canal and a shorter fundus. You can reverse all those changes and get it ready to accept an embryo, should you be so willing to do so, So you can actually reverse all those changes. And the most obvious place where you can demonstrate this is the uterus. Those uteruses have successfully been changed, especially, let's go for a Turner syndrome or for a premature ovarian failure, for example. And you can see that the uterus, you can actually change it from your atrophic organ with low vascular, with low perfusion. You can change its connective tissue and collagen and muscle mass as well to get it to a normal reproductive sized uterus, which is able to successfully accept an embryo and carry a full-term pregnancy. And that to me is fantastic. And of course, the vagina as well.
Well, most of the questions are alike, and I know that you've answered most of them. And the others are compliments for the webinar, for the quality of conferences, and the high caliber of our guest speaker. However, the great number of subscribers to this webinar is encouraging us in the Middle East Fertility Society to consider having a workshop or a postgraduate course or even a session on menopause. And hopefully we'll do that in our next meeting in Amman next from the 3rd to the 5th of December. And we will be in touch with you guys. It's been great pleasure.
Thank you,
Michelle. It's been a great pleasure.
Thank you, Michelle. Thank you, Michelle. I'm sorry I ran over a bit. But it's very nice meeting you, Dr. Aber, Amr, Hassan, of course, Mina, and all of you.
Thank you very much, everyone, really. And there's a question from Dr. Laila Al-Arifi saying that in the Middle East, HRT is unknown area for many doctors and patients. How we could change this attitude?
By awareness, we have to raise awareness about menopause. Menopause, it doesn't mean hormone replacement therapy. Menopause is that it's an era in the woman's life that she will spend around 30 or 40 years of her age into area of menopause. So it's the area in which we have really to raise awareness about the importance to keep a good quality of life. And it's not only HRT, it's diet, it's exercise, how to prevent diseases. HRT is part of it only when it is needed. When you have hot flushes, when you have symptoms that will push you to use HRT. But menopause, now people, patients and women are living longer. So now average age group of Jordanian ladies is 81 years old. So I'm having 30, 40 years of my age into the era of or age of menopause. So it's the quality of life. I have to empower the woman to express their feelings, and I have to raise awareness to the people who can make a change, like the Ministry of Health, the governmental societies that can, empower the woman and, make their life more secure in the coming 30 or 40 years. So it's a lot of work. We here in Jordan, we have the Jordan Menopause Society since 1999. We're working on raising awareness about menopause. We're doing lectures, we're going on the media, we're doing walks, and we have to educate the doctors before the patients, because many doctors after the WHI, are not using HRT. They don't know how to prescribe HRT. We have done a study in 2016 with the MSD about the awareness of menopause in Jordan here. It was 1,500 ladies. And, the awareness was about breast cancer, heart disease, osteoporosis, not menopause. And the patients, when you asked them, do you know about menopause? He said, yes, I've heard about it. Do you have symptoms? Yes. Have you been managed? She said, no. My doctor never mentioned a treatment for my hot flushes. 50% used tranquilizers and painkillers and Panadol for the HRT. So it's the doctors also that has to be, involved with our awareness after the WHI study. So it's a joint work between the doctors, the government, the Ministry of Health, you know, to raise the awareness and to empower the ladies about menopausal age.
Okay, before giving actually the final word to Professor Michel and Professor Salam, I really would like to thank all the speakers, starting from Dr. Nick Panay, Professor Mark Brinkat, and Dr. Abir Annab, and also us thanking Eva Pharma for that. I also would like to thank all the participants. We have participants from 40 countries. Actually, there are 39 countries and one from Malta. So it's 40 countries. So it's really great. And I think the feedback is great. You know, if you look at the chat, the feedback is great. And many of them are asking for another, either for the presentations or asking for another webinar for that, you know. So thank you everyone, really. And I would give the final word to Dr. Michel, Professor Michel and Professor Salam.
Well, thank you all, dear friends. It's been a great webinar. And thanks to you, Hassan, that this combined work has made the sort of getting out of the lockdown and getting together with our friend all over the region, even virtually. I would like also to thank Mina Murad and Eva Farm for their contribution. And I would like to invite you, Hassan, that our next webinar will be on andropause, because men here are very machos and they don't want to talk about it. So let's talk about it in one of our next webinar, and that will be important as well.
Okay, thank you very much. Thank you very much, Michel. I think when we reach the age of andropause, we will start discussing it. Yeah.
You're an optimist, Hassan.
Denial.
It's denial.
Yeah, denial phase first, and then
Denial.
But really, thank you very much, all the speakers, Professor Brinkat, Dr. Abir, and Professor Panay, of course, and the moderators, Professor Amr Nouri, Professor Michel, and thank you again for Eva Pharma, Dr. Mina, and all the group. And as we say in French, à la prochaine. And we hope actually to increase our work on the menopause, as you said, Michel. And thank you, guys, and good night.
Good night.
Great night. And I will send you all the feedback of the people to tell you how impressed they were. Thank you very much.
Thank you. Thank you so much. Thank you, Hassan. Nice seeing you.
Bye-bye.
Bye, Mark.
Bye-bye. Bye-bye, Michelle.
Bye, Mark.
Bye, Abir.
Bye-bye.
Bye, Mina.
Bye, Abur.
And Dr. Benjamin.
Good night.
Bye.
Good night. Stay safe. Stay safe.
I will.
You too. Hasta luego. Hasta
luego.
Hasta luego, amigo. Hasta luego.
Bye.